Hot day today. Don't say that. Okay, but it's my favorite thing ever. We're going to talk EndofLife day. It's my favorite subject. It's going to be great. But we are going to start with oncologic emergencies because this is going to be shorter, and that way I know exactly how much time I have for EndofLife and let y'all out on time. I do not want to rush EndofLife. So we're going to start on emergency. And then also, just because I think transparency is good, we are going to take a break at 2:20 regardless of where we are, because I have to check in for a flight. So we're going to take a 10-minute break at 2:20 so I can get checked in. Let's hope that they don't cancel this round of flights. And then we'll get back to minutes later. So if you're wondering the weird timing, it's for purely selfish reasons, but I do want to get to this conference. So
wait, what?
With that, let's dive in to oncologic emergencies. So y'all learned about cancer before, right? Cancer is what? Bad. Yes.
Boy.
Good. Moving on. So what is cancer? Uncontrolled cell growth, right? Rapidly dividing cells. They don't have the right nucleus. They're invading space wherever the tumor is. Either that organ can't function or it's going crazy and over-functioning. Okay, so we know cancer. Today we're going to talk about what are those oncologic emergencies. These are complications that can arise from cancer that can have life-threatening implications, and we have to respond quickly. Okay? I'm not going to read your objectives, but there are 6. How about that? We got 6 things to work through today. So again, oncologic emergencies, these are life-threatening. These are not something to be like, let's just watch and see how this goes. Like, we need to be intervening when we see it. Ideally, we want to be on the lookout and prevent it from even emerging, if we can. A lot of times, these are caused by cancer itself, but we can also see it caused by chemo or radiation. The treatments that we give can actually cause damage, which then creates emergencies. We do know these have typically a fairly high mortality unless we can get in, respond, get it addressed quickly. And because it has such a high mortality, the earlier we can find it, the earlier we can then intervene, the more likely we are to save that person's life. Okay. As we think about nursing interventions, patient education is going to be critical here because not only do we need to be able to early recognize, but we want our patients and their caregivers and family members to know what to be on the lookout for so they can catch it early and they can seek health care as quick as possible. So these fall into different categories. So this first one is an obstructive, meaning that there is something obstructing that's getting in the way. So typically this is going to be the tumor itself has grown to such a size that it is now pushing in on healthy tissue and preventing it from doing its function. Y'all have learned about these probably with like types of shock maybe, like obstructive, something is blocking blood flow. So the first one, superior vena cava syndrome. What is the role of the vena cava?
Brings the blood back.
It brings the venous blood back from the body into the heart. It drains into the right atria. We know there's an inferior and a superior vena cava. The inferior vena cava is what's bringing the blood from the lower part of the body down. Superior vena cava is what's bringing the venous return from the head and neck into the heart and the upper extremity. So kind of above the heart is where we're getting blood from. So when we have superior vena cava syndrome, we're going to see issues with drainage of blood from the superior vena cava into the right ventricle. Not right ventricle, right atria, sorry. So what we see is that the tumor gets so big, it pushes on the vena cava. If we're pushing on the vena cava, that lumen, that diameter gets very, very small. We can't let a lot of blood flow through. It could also be possibly a thrombus, that if there's a thrombus forming because of the cancer or because of the treatments, that's also not like a DVT. We're not talking that. There's like a clot in the chest, or that's also pushing on it. We can see it. But more often than not, it's a tumor. So it's either pushing from the outside, or it grows so big and that cancer is so aggressive, it starts to actually cross through the vasculature and starts to fill inside the lumen as well. But the biggest thing is it cannot drain. We cannot get the venous return out of the upper extremity. We cannot get the venous return out of the head, and we can't get it through the neck down into the heart. So if you can't get the blood flow into the heart, where does it back up?
The extremities.
Everywhere it's supposed to come from. And veins are very compliant. We know that they can stretch, right? They're not as strongly muscular as arteries. They can stretch and stretch and stretch and take on more fluid. That's what happens. So we're not getting drainage. It doesn't happen a ton. This is like 3 to 4% occurrence, but it's life-threatening. All of these are life-threatening. So who gets these? A lot. Think about, it's going to be those cancers that are going to be right around where the vena cava is. So lung cancer is notorious for this. The lungs are very close proximity to the heart. They're very close proximity to the vena cava. So we tend to see most of this occur in lung cancers. There's lots of lung cancers that can be fairly aggressive as well. Lymphomas are notorious for also, so lymphomas where we have cancer in our lymph nodes and our lymph tissue. There's a lot of lymphatic vessels, a lot of lymph nodes inside the chest. If the Hodgkin's lymphoma, if it gets into those lymph nodes in the chest, those lymph nodes can grow so big they impede on the vena cava. And then any metastatic tumor. What is a metastasis? What is a metastatic tumor?
A stage 4 tumor that spreads to other locations.
Right, it started somewhere else, and it landed in a place it's not supposed to be. And the reason we know it's metastatic is if we biopsy it, it doesn't look like the tissue where we found it. You take a little piece of lung tissue and you look at it under a microscope, and it's definitely not lung tissue, but it kind of looks like liver tissue, and we found a tumor in the liver as well. We knew that that liver cancer broke off and landed in the lung. So metastatic is where there's some tumor somewhere else that ends up breaking off a piece of it, not a Kit Kat bar, y'all, breaking off a piece and landing in the chest, and then getting its blood supply, starting to rapidly divide and creating a new tumor. There's certain cancers that are very prone to metastases, so we could see those. We could also possibly see it if you've got a central venous catheter. Again, this is that idea of a thrombosis. We've hopefully all learned, like for chemo administration, a lot of times they're going to get a portacath, they're going to get that central port that they can tap into. That's a central catheter. That could develop a thrombus on the catheter lumen that could obstruct the vena cava, because that's how it's getting into the heart. It's sitting right there in the vena cava. Or if we have any radiation to the central part of the chest near the heart, it could create a thrombus, it could create tissue that can impede it. So how do we know? Well, we're going to do an x-ray, and when we do the x-ray, we're going to see hopefully this mass, we're going to see this big thing taking up space. We might do a CT scan to get the full extent of what we're looking at. If we kind of do a cross-section of the chest, see how big are we dealing with this, how much blood flow is being obstructed. Diagnostic, best thing would be a venography, so putting contrast into that vein, seeing the blood flow through the vena cava to get an idea of how impeded is this. Okay, so we understand what that would be. So what does it look like? Well, blood's not draining out of where blood's supposed to drain from. You're going to get a backup of blood. You're going to get a lot of venous congestion in the skull, right? So the veins of the brain are going to start to fill with blood. Y'all learned about intracranial pressure, right? Like the skull is a fixed structure. If the blood starts to fill up, we're going to start seeing increasing intracranial pressure potentially. That can progress to seizures. That's where those seizures come from, is our ICP starts to elevate. In the chest, again, you got this big tumor sitting in the chest. We're not draining well. We're going to see respiratory manifestations. They're going to have a cough. They might have chest pain from that pressure. They're going to have shortness of breath. All of this is because not only is that tumor pushing on the vena cava, it's also messing with our breathing as well. So we're going to see respiratory impairment. When we look and we have them sit up at a 45, or sit upright, we have them turn their head to a 45, we're looking at the jugular vein. That thing is popping out. That jugular vein is so distended. You don't need to get a ruler. You're like, that's pretty distended, okay? We can see it not only in the jugular vein, we can see it across the veins in the forehead and the head. We can look across, if you look here, you can look across the chest. All of those veins in the chest, even these small little venules, right, that we normally wouldn't see, they're going to be big and bulging because they're filling with blood. We're also going to see, because of that buildup of venous congestion, then we start seeing fluid leaking into the tissues, right? We learned this with peripheral edema. When the veins fill up, then the plasma starts to leak out. You have that third spacing. Same here. We're going to see shifting, third spacing into where the blood's not coming from. So it's going to be our trunk is going to get swelling. Our upper extremities are going to start to swell. The face is going to swell. Anywhere the blood is accumulating, we're going to start seeing edema. Their legs are going to look fine. The upper part. So what do we have to do? We want to try to figure out who's going to be at risk for it. If you're somebody who has lung cancer, you're somebody who's got a central catheter, you're someone who's got lymphoma, you've got metastases that have now landed in your chest, you are now a high risk. We're going to teach you to be on the lookout for this. If they start to see, man, I feel a little puffy today in my face, we need to be alerting then. Not, okay, I can't breathe anymore. We need to be on the lookout. This is going to be highly anxiety provoking, right? You're having a hard time breathing, your face is going to swell. Very high anxiety, very scary distress with this, so we want to do some good, if we can do relaxation strategies, but how to try to help regulate the anxiety. We are going to have perfusion issues here, so we're going to maybe provide supplemental oxygen. We might give diuretics. We got to be kind of careful of that though, but we've got to try to get that fluid out, maybe. We don't want to go crazy with it, because it's not that we're low on fluid. It's just it's not getting where it needs to go. Steroids can help reduce some of the inflammation, hopefully try to open up that pathway a little bit more. Definitely anticoagulants. We don't want this obstruction creating a blood clot. Now we've got a whole other set of issues. Best treatment though is we got to get rid of the bulk. So we might do radiation, try to shrink that tumor. We might do chemotherapy to try to target that, kind of get that tumor to shrink. If we can shrink it, it's going to get the pressure off the vena cava and blood flow should be restored. You want that patient upright. If you lay them flat, the blood's not going to flow as easily, so you want to sit them upright. It's going to help promote drainage out of the neck help promote drainage as best as we can. It's also going to help with oxygenation. If the person's sitting upright, the chest can expand more easily. When they're laying flat, the whole chest wall has to fight gravity. So get them sitting upright in semi-Fowlers. We're going to monitor their tissue perfusion, monitor their fluid balance. Treat this just like any patient you've learned, when you're like, we're worried about lymphedema. So people who've had mastectomies, people who have a dialysis graft in arm, those things you learned, you never, ever, ever do a venipuncture on this. For people who have superior vena cava syndrome, you never, ever, ever use either upper extremity for IV starts, for blood draws, because they are not able to drain the fluid out. You put a tourniquet on that extremity, you're just going to keep more fluid. You're going to make the issue worse. So for these individuals, we're not doing VP. We're not putting any kind of tourniquet or like a tightening device on there. One of the few times we might look at a foot, right? They probably said, never put an IV in a foot. Okay, well maybe in this situation we have to work with the team, find a different site. We also don't want them to strain. Why would straining be bad? It's going to increase your thoracic pressure. It's just going to create more congestion. It's going to limit blood flow even further, and it can cause you to pass out. We don't want that. Okay. So that's superior vena cava syndrome. It's going to be a quick one today. I'm hoping. Spinal cord compression. By the way, yes, spinal cord injury is an online module.
Yes.
It's going to be posted in that. Promise. I know no one's looking at it. Hopefully y'all are studying for the test tomorrow. But I promise you it's coming. It's just I'm starting from scratch with all my lectures, so it takes me a little while to get through 7 hours of lecture every week. So promise it's coming. Spinal cord compression. This is where a tumor is literally growing and pushing in on the spinal cord. If the spinal cord has pressure on it, it's not going to function. And so anything from that level of tumor below can lose motor function, can lose sensory function, or both. This is a neurologic emergency because they are going to be essentially paralyzed from the level of that tumor down. If we don't restore, or if we don't decompress the spinal cord, if we don't allow those neurons to continue to get blood flow again and to fire effectively, this could be permanent damage. They could be permanently paralyzed from this. With that tumor, not only is it going to be pushing on the spinal cord itself, it's going to be pushing on the spinal arteries that provide arterial blood to the spinal cord. So not only are you getting pressure on the spinal cord, where it would make it not work, you're also going to have infarction of the spinal cord. It can also, not only can that tumor grow into the spinal cord, it can also grow into the vertebral body or the vertebral arch. And so it can cause that bone to basically be eaten away. And you can see that that entire vertebrae collapses when you break the back. So we see this again with metastatic disease, so 5 to 10%. These are going to come from those highly metastatic cancers. So breast cancer is notorious for going outside of the breast. Lung cancer is incredibly metastatic. Prostate cancer is one that will typically, if it metastasizes, it's going to lodge in the bone. Okay. I lost a grandfather to bone cancer secondary to prostate cancer, and my husband lost a grandfather to bone cancer secondary to prostate cancer, interestingly, in the same month. That was before we knew each other. Like, it was meant to be. We were grieving at the same time. But prostate loves the bone. So prostate cancer in of itself, highly treatable, but if it gets to metastases, we're going to typically find it in a bone. Kidney cancer can be really aggressive. Y'all can read these, but these are the cancers that are more likely to metastasize. There's other ones that tend to behave themselves more and stay put. But these type of cancers love to get into that bloodstream, and they love to land in the bone, particularly in the spinal cord, in the spinal area. So thinking about what would this be? Again, wherever it lands, if it lands in the cervical spine, they're going to lose function from the cervical spine down. If it lands in the sacrum, they're going to lose function from the sacrum down. It all depends on where they have that tumor developing. How would we know? Well, first they're going to say like, hey, I can't feel this, or I'm having some weakness. Hopefully we catch it in early stages of impairment. We would do x-rays, myelograms, and we're going to kind of see like how is the spine functioning. We might look at the bones, MRI, CT. Again, basic thing with these is we got to find the tumor. We got to see the tumor, see how big it is, see what surrounding structures it's impinging upon. Is it pushing on the bone? Is it breaking down the bone? Is it pushing on the artery? What is this thing compressing? So, it's going to start as weakness. You start to impair motor function, you're going to have some weakness at that level of tumor and down. If it gets worse, you might start to have some paresthesias or some numbness, but if it gets to the point where that cord is compressed, you will have paralysis and a complete loss of sensory function. In the musculoskeletal system, this is going to be painful. If this thing is eroding the bone, there's going to be back pain. If this thing is causing ischemia to the spinal artery, and we're getting tissue ischemia, think about a heart attack, right? The pain comes from the ischemia, same thing. We're going to have very, very severe pain in the back wherever that tumor is. When we find it, you start palpating down that spine. That spot where that tumor is probably going to be tender because the bone is eroding away. They also, because of this pressure, if it's anywhere kind of above the level of the bowel or bladder, they're going to lose control of the bowel or bladder. And you're going to learn more about that in spinal stuff because I'm literally recording that before and after this class. So more to come on that. So what do we want to do? We want to limit their activity. We have a lot of instability in that vertebrae. We don't want them to be really aggressive and end up causing that bone to fracture worse. Pain management is going to be critical because this is very painful. Make sure we're protecting the patient. If they're getting up to walk, we need to be with them because their motor weakness could be progressing. And they think they can walk okay, but that tumor's worsened the condition, and now they're not as strong as they thought they were. We're going to monitor their neuro. Where's the tumor? Everything down. We're going to keep testing motor and sensory at that level. What's the goal? The goal of treatment is try to shrink that tumor. Radiation works pretty quick, so we might do some radiation to try to shrink that a little bit down to remove some pressure. Steroids can help with inflammation that's going to be associated with this, but a lot of times they have to go in surgically and remove that tumor, and maybe remove part of that vertebrae and put in something else. Okay, and then over time, we're going to do rehabilitation. If we can prevent long-term damage, if it's just temporary impairment, we get that tissue or that tumor out, we restore good blood flow, we restore good spinal cord function. None of the neurons died, they could hopefully have rehabilitation and regain function. If this got to the point where the neurons have become ischemic and they've died or they've demyelinated, it's done. The damage will be permanent. Okay, so those are obstructive. Again, the tumor or something is pushing and obstructing blood flow or function. Now we're going to talk about metabolic. This is where the cancer cell itself starts making hormones. Tumors, typically, those cells, remember, they're rapidly dividing. They tend to be more in towards the stem cell stage. They tend to be very immature. They can sort of call on functions of other cells that they don't normally have. So they can start doing things like, you should not be making that hormone, but they're able to do that. Because again, remember, the DNA is doing all sorts of crazy things with these guys. Okay? Or we can see that the cancer treatment itself is messing with our metabolic processes. Okay? So, y'all learned these. Isn't that nice? Y'all learned this, right? We talked about it again. Oh, wait, no. Teach it to me class. I talked about SIADH with foundations, but I know you learned it in foundations because I had to teach about it. But y'all learned about SIADH, right?
Yes.
Okay, so what is SIADH? Yes, that's what it stands for, but we're making too much ADH. My little trick here is SIADH. You have too many letters, you have too much ADH being made. The opposite is what? Diabetes insipidus, DI, the first two letters of that is of diuresis, is also DI, so it's DI, you pee a lot. SIADH, so too many letters, too much ADH. But this is not because of a brain or pituitary issue. This is because cancer cells somewhere mutated, and all of a sudden they start releasing ADH into the blood. If the hormone is there, the cells of the body don't know where it came from. They don't know it didn't come from the brain. If the hormone's there, it's going to respond. This is where medication and safety comes in. If you give the medicine, it's going to work. Whether it was safe to do is up to you. Same thing. If there's something making ADH, the cells of the body will respond. What does ADH do? ADH causes the nephron of the kidney to reabsorb lots of water. The only thing it does is reabsorb water. It doesn't mess with any other electrolyte. So what does that mean? The person who's got SIADH, because the tumor cells dumping ADH into the blood, is reabsorbing lots and lots of water. And as they reabsorb lots of water, they're also diluting out their sodium. So it becomes a hypotonic hyponatremia. This person's got so much water in the serum, it's diluting out their sodium concentration. So who's going to make abnormal ADH? Man, lung cancer is evil. Those lung cells, they can metastasize, but they also are notorious for doing this ADH production. We can also see it some with duodenal or pancreatic or Hodgkin's, but most of the time, there's some small cell or oat cell lung cancer that's making a problem for people. So they're either making the ADH, or there could be a tumor. It could be that we gave chemo. And chemotherapy destroys rapidly dividing cells. It could be that a side effect of the chemo is that it messes with how the pituitary gland regulates the production of ADH. And now all of a sudden, the pituitary gland can't turn it off. It's just going to keep making ADH. And it's a side effect of the chemotherapy. We can also see with some medications, but in the world of cancer, chemotherapy, we're trying to treat a tumor, and now we've caused some damage to the pituitary, and now we're making too much ADH. How do we know it's happening? Well, this one we don't have to get too crazy. All you do is look at the symptoms and draw some blood. We're going to see low sodium. Their serum osmolality is going to be low. Their urine osmolality is going to be concentrated. Why would that be? They've got all this ADH, and it's reabsorbing all the water. What's not being made? Urine. We're not making, there's not a lot of water getting into the getting through the nephron to make urine. So we're going to have very concentrated urine. But the kidney functions fine. This is not an issue of acute kidney injury. This is an issue of ADH. So we can look at labs to kind of figure out what's going on. So it's going to look like everything you learn about with SIADH. You're going to see those issues of hyponatremia. When you think sodium imbalances, I always want you thinking brain. The brain is incredibly sensitive to sodium, so we're going to see lots of neurologic changes. If it gets very severe, we're going to see where the brain, there's fluid shifting. We're going to start seeing cerebral edema. It progresses to seizures and coma. Anytime the brain's not functioning, the rest of our neurologic system's impaired, so decreased deep tendon reflexes and weakness. Now, have I told you all my thinking on anorexia, nausea, vomiting? Okay, so, no? I can't remember. Maybe? Did I know? It was the ABGs, right? Like, okay, all it tells you is somebody's unhappy somewhere, but it's not super helpful. Okay, yes, this is another case where nausea, vomiting, anorexia. Great, there's a problem. Sweet, we know there's not a problem. Now we know there is, now we gotta do more digging. Why would they be having weight gain? They're retaining all this volume. Typically though, it's not gonna cause edema. We don't have all this crazy imbalance where now we're pouring tons of fluid out. But we are retaining water. So what do we want to do? Well, we want to fix the cause and treat it. I feel like that's always the staple, like find the cause and treat it. We're going to very closely monitor their neurologic system. We're also going to very closely monitor respiratory assessments. This can progress to impairing respiratory function. We're causing some mild edema and impairing respiratory function. We're going to do strict eyes and nose and weigh the patient. We want to see how much fluid is being retained. Obviously, we're going to put on seizure precautions since there's that sodium issue. So we want to restrict oral fluid. If the bodies just keep reabsorbing water, let's not add more to the system. The tank is already full. We don't need to be adding more. We're going to monitor the sodium. We probably are going to encourage them to eat salt. Now, how many patients have you taken care of where you're encouraging them to eat salt, right? Most of the time it's a low salt, avoid salt diet. It was the weirdest day when I had to give a patient, he was hyponatremic, I had to give him salt tablets. Like, I feel like something is fundamentally wrong with having him swallow salt. And he was waiting for a heart transplant. Like, you have cardiovascular disease and I am giving you salt. But he needed it. If we can't do oral, we might give some hypertonic sodium. Now, where do you have to give that? Hypertonic saline? Only in the ICU. In big veins, in ICU, we have to very closely monitor these patients. We might be giving them some Lasix to try to get some of the fluid out. There is a new drug that we might give that just promotes the excretion of water and it doesn't mess with electrolytes, so we might try that too. All right, the next one, hypercalcemia. This is another one. Y'all learned this. Might have been a hot minute since you learned about hypercalcemia. It feels like Monday to me because that's when I taught it at the foundations. But hypercalcemia is when you have a calcium that's greater than 10.5. You have too much serum calcium. Calcium is very important in cardiovascular function. It's what helps make the electrical conduction of the heart. It also is what helps with muscle contraction, so it can be involved with the diaphragm functioning. Now remember, well hopefully y'all learned, with calcium, it typically is bound to albumin. So if somebody has poor nutrition, they could have an abnormal calcium. So a lot of times we have to do what's called, we have to correct for that. So there's this formula here where we want to see, okay, what's the actual calcium considering your albumin status? Am I going to ask y'all to do that? Just know that's a no. You do not have to know that formula, but just know we have to be able to consider albumin, because if there's not albumin, it makes it look like we have low calcium just because we don't have as many binding sites available. So this is fairly more common. Interestingly, sometimes we find cancer because somebody comes in for hypercalcemia. When I see hypercalcemia for patients, the first thing I'm wondering is where's the tumor? There's other reasons that can occur, but typically we see a pretty strong association with cancer and hypercalcemia. Because it works for cardiovascular and respiratory and muscle function, very high mortality if we don't get that calcium back into a normal range. So we have got to intervene because hypercalcemia can cause cardiac arrest. So all these others were emergencies, this for sure, because this is an electrolyte imbalance. It can very quickly cause death from a cardiac arrest. We see this a lot with, again, these very aggressive tumors. Breast cancer is very aggressive, lung cancer is very aggressive, renal is aggressive. Multiple myeloma is just, it is a beast. But a lot of times, we'll see it in bone metastases. If you're breaking down bone, where's most of the calcium in the body? In the bone. If you're breaking down bone, that's what these other tumors are doing. They're breaking down bone. It's leaching that calcium into the blood, so we get hypercalcemia. There's a medication that can cause this. And if the patient's immobile, then what happens is the body's not getting the signal that it needs to be keeping those bones nice and strong, so it starts breaking down the bones as well. And if they're dehydrated, it's going to raise the calcium because it's going to let the calcium bounce together more because it's not as much volume. So what do we see? Neurologic, we're going to see a depression of the neurologic system. So what I was telling the students Monday is I kind of think of calcium as the parents of the body. Like when they're there and it's the right amount, everything's functioning normal, heart's working well, muscles are working well, brain's working well. When you have hypocalcemia, it's like the parents went away for the weekend and the high schoolers had a rave, right? They had all their friends over and there's a party and everything's revved up. That's Tavastic, Trousseau's, everything's got tetany and tachycardia. But hypercalcemia, it's like the parents are there and the really strict aunt and uncle that nobody ever wants around is coming to visit and there's nobody having any fun everywhere, everything's depressed. So hypercalcemia is going to depress neurologic function, it's going to depress cardiovascular function. So we're going to see kind of some changing in thinking, some fatigue. Fatigue's on there twice, I guess they get very tired. Bone pain from the bones being broken down. They're going to have dysrhythmias, typically bradycardia. It can progress to cardiac arrest. They're not going to feel good. So anorexia, nausea, vomiting. But not only that, but the GI tract's going to slow down. Everything's suppressed and slowed. So we get constipation, and it can progress to an ileus where the GI tract just stops working. Because all this calcium is flowing in the blood, it's going to damage the nephrons when it gets to them, so you're going to have renal insufficiency. If the calcium's hanging out in the urine and bouncing together a lot, that's going to form together and make a lovely kidney stone. So let's add some pain to this. And it's very bad for the kidney, so it can progress to kidney failure. So how do we fix it? We got to find the cause and treat it. We're probably going to give bisphosphonate. It's going to help prevent the bone reabsorption. It's going to say calcium, you need to stay in the bone where you belong. We're going to try to get more urine production. We're going to try to hydrate. We're going to try to get diuretics. We want to get that calcium out of the blood. The way the body regulates calcium is through the kidney primarily. That's how we get it out. So we got to pee more to get more out. If we can safely do it, let's get them up and moving. Encourage the body to be redepositing calcium in the bone. But ideally also, let's shrink the tumor. Let's find the tumor. Let's address the tumor that's causing this breakdown. Okay. This one makes me cringe. This one is like evil. Y'all have heard of rhabdomyolysis? It's nasty, right? Y'all learn. Tumor lysis syndrome, in my mind, is very similar to rhabdo. It's very different in its pathophysiology, but the outcomes are fairly similar. This typically is a consequence of chemo or radiation. So in the attempt to treat the tumor, we're shooting it with radiation, we're giving aggressive chemotherapy, it's breaking down those cells as fast as it can. Whenever you break down cells, the contents of those cells have to go somewhere. This is not normal apoptosis where the cell's broken down, the body reabsorbs the components and repackages it. This is just mass destruction. So because of that, you have all of these cell contents being released into the vascular system. You've got DNA, you've got RNA, you've got all of the cytoplasm and everything in it, the calcium, the potassium, everything that should be in the cell is now in the blood. It's not going to happen right away. We know chemotherapy kind of takes a little time to get up and running, and it can work up to like a week sometimes. So we're going to see it in that period. So this is going to happen when people are home. Patient education is critical. We have got to let them know about this. We see it a lot with our blood cancers. So our leukemias, our lymphomas, lung multiple myeloma are very aggressive tumors. It can last for a period of days, and we're going to use our lab results. So essentially, you've released all this content, and it's all going to land in the kidney and kill the kidney. So what is kidney failure? Well, we're going to have hyperuricemia, right? We can't get uric acid out through the urine, it's going to stay in. So they've got this acute kidney injury. They're going to have all those issues with hyperuricemia. They could even get that itching. They're going to have hyperkalemia. Potassium is mostly intracellular, so you release all this potassium, you're going to have hyperkalemia, and you also have kidney insufficiency or failure. We know kidney failure, you see hyperkalemia. The kidney can't get the potassium out, so you're going to see the weakness, cardiac dysrhythmias. We're worried about cardiac arrest with potassium, right? We're all on that page. When we hear potassium issues, you're like, where's the peak T wave or the U wave or any of those things? So this, we're worried about a peak T wave, hyperphosphatemia. Again, the kidney's not working. And because we have hyperphosphatemia, we say hypocalcemia. So this is where everything's revved up. We have tetany, Chavastics, Trousseau, Schizer activity. So we want to figure out who's at risk. Patients that have those types of cancers, we're doing lots of education, especially if we're giving them chemo. Chemo is the problem here for a lot of these patients. We're trying to fix the problem, we make another. So we're going to watch them closely, do lots of patient education. If it occurs, we're probably going to have to do dialysis. At least a few rounds, because we've got to clean the blood somehow. The kidney is not working. We might have to do temporary dialysis, hopefully not permanent. But they might need dialysis ongoing. We're going to treat the uricemia the same way we learned it before. You're going to give allopurinol, you're going to increase fluids, if you can get the kidney to pee again. We know that kidney failure and uric acid, the acids, that's going to cause acidosis. We're going to try to counter that with some sodium bicarbonate. Hopefully y'all have been like, oh wait, acidosis. We figured out the arm thing yet? You're like, it's not on this test, so no. No worries. Hyperphosphatemia, we get those phosphate binding agents. We want to get it out of the blood and hopefully out through the stool if we can. You're going to give calcium supplements because we know calcium and phosphate are inverse. So we can give more calcium. Hopefully we can cause excretion of phosphorus. Make sure they know to take the allopurinol. So many people are like, I don't want to take it. Okay, well sure, deal with hyperuricemia then. Take it. We're going to, by the way, for hyperkalemia, we're going to restrict potassium. Y'all know we can give, how does potassium get into the cell? Gets in with which hormone?
Insulin.
Insulin. But you can never give insulin unless you also give glucose, right? So you could give glucose and insulin. It should help to drive some of that potassium into the blood. That's a temporary fix, though. All right. So our last one is going to be an infiltrative emergency. This is where cancer treatment is going to cause an infiltration of the organs. So this isn't any more pressure. This is not metabolic contents being released into the blood. This is about the tumor invading. And the one we're going to talk about is cardiac tamponade. Y'all learned about this. Isn't that the nice thing about this? Y'all learned a lot of all this. Now you're just learning a new cause. None of this, like treatment for a lot of these should be surprising. They should hopefully be reviewed. Cardiac tamponade, hopefully we all know, this is life-threatening. In cardiac tamponade, the pericardial sac is filling with pericardial fluid because it can't leave. In this situation, it's a tumor. The tumor is invading and restricting the pericardium. A lot of times also, if we've had any kind of radiation to the chest, that radiation has scarred the pericardium and it can't relax, it can't move like it needs to. So it's almost as if, we were pinching on the pericardium. So again, have you all seen lung and breast on a lot of these? Yeah. They're aggressive, they're rough. Sometimes it can occur rapidly, sometimes more slowly. If it's associated with radiation, it could happen fairly more rapidly. We'd have to look at the heart, so we're going to do an echo or a chest x-ray. Y'all just learned this recently, right?
Yes.
Isn't that like on tomorrow's test?
Yeah.
Okay, so like hopefully this is a helpful review for tomorrow. How about that, right? So what are we gonna have? We're gonna have chest pain because the heart's not able to receive preload, right? And that restriction's also not gonna let the blood leave. It's a high resistance, so that's your afternoon. Okay, so we're having chest pain. They might have a heavy feeling in that chest. The heart sounds are gonna be muffled. You can't hear it because you're trying to get through fluid now. Does this all look familiar? Jugular venous distension because we're not able to get the blood into the heart. The heart's going to be working overtime, so we're going to have tachycardia, but we have decreased cardiac output. We're going to have low blood pressure because there's not blood getting into the vasculature. They're going to have shortness of breath. We're going to see a fluid buildup in the lungs, so it's going to affect respiratory function. Can also cause irritation and like hiccups and hoarseness and things like that. Very, very anxiety-provoking. If we're not perfusing the brain, if we're not getting cardiac output up through the carotid arteries and into the brain, it can decrease our level of consciousness. It can also, because of all of that buildup, it can cause swallowing impairments. Again, if it's messing with the heart, it's going to affect blood flow, and it gets in the neck area, it's going to affect what's going on there. So hoarseness, swallowing issues, those sorts of things. They're going to be sweating because they're like, the body's working in overdrive. So first, we've got to figure out what's going on. We're going to do a good assessment. Go learn all this. We're going to elevate the head of the bed, get them on some oxygen, get that fluid off if you can, give steroids to help, probably to try to help with any inflammation. You might need vasopressors to help offset the low afterload. But main treatment is drain the fluid, right? That pericardiocentesis where you go through with a needle or a window and you open up that pericardial sac and you drain the fluid out. Either surgically or through just a needle. But if it's from radiation, chances are that pericardial space could be sclerosed. It could be very scarred over. So we might need to be thinking about more aggressive treatments for that. Boom. How's that? Short and sweet. So the good thing is most of that, some of those like manifestations and treatments should feel fairly similar. It's the causes that we need to focus on as well. Okay? Now, if any of that you're like, that doesn't feel like review, that feels like new information, I'd encourage you to go back to your notes you learned from hyperkalemia or any of those things, like do some helpful review with that. Okay? So, let's take a break now, and knowing like we're going to do a little bit of time and then take another break. So if y'all will come back, I do ask that you come back. But also, out of respect to your peers, if you have a colleague that needs to take a break, that needs to leave the room for a little bit, please respect that they have a grieving process that they might be needing to go through. Y'all could just have to go back and I don't know what I'm saying. If there's a grieving process, be mindful of the fact that they may not want to talk about it after class. So if somebody leaves, don't be like, hey, are you okay? What was that about, right? Just be mindful that everyone, there might be reasons people need to step out. If you don't come back, I'm going to worry about you, and I'm going to try to find you, and I'll probably be like, hey, are you okay? And we can talk. But I just want to put that out there, that if at any point you're like, nope, can't do this right now, you're welcome to just go out, take a break, get a little water, and come back. Okay? Sound good?
Yes, ma'am.
Okay. I just don't want anyone to feel like she's forcing me to talk about this right now. Okay. I am going to force you to talk about it, but I don't want you to feel trapped in your seat. So we're going to talk about end-of-life care. Some of you might have already been at the bedside where you had to be providing end-of-life care. ICU, critical care settings, the ER is notorious places where we're going to see a lot of this, but you're going to see this everywhere. Unless you plan on working in medical records at a department of one person and you never want to interact with a human being, if you plan on being a nurse, you're going to have to know how to do end-of-life care. We see babies die in utero. We see neonates die. We see kids die. We see moms who have delivered babies or were pregnant die. So if you work OB, you can see it. Definitely in the adult world. Every one of you, unless you like leave the nursing profession, which please don't. We need to.
But what is the difference? Is it the same or not?
You're going to see this. And one of the most difficult things about this is that our society, we don't really like to talk about death too much. We get kind of uncomfortable about it. A lot of you guys are like, ooh, talk about death. She's already said the D word more times in like a minute than I've said it in 2 years, right? Dead, death, dying. We don't talk about it. Because we don't talk about it, then when we're asked to do that and be at the bedside and be present with somebody who's dying, we feel very awkward. We don't know what to say, we don't know what to do, hence me being here today to talk about what are some things that you could say. More importantly, what are some things that you don't have to say? When can you just be silent and be present? So we're going to sort of use today as a way to build a little toolkit of things that you could say or do when you're at the bedside of somebody who's dying, so that we can facilitate them dying well. Okay? People can die well. There is a way to do that. All right, so a lot of things to talk about today. I want to make sure that we're all on the same page with terminology. And as much as I am very much against putting lots of words on slides, like long sentences, I want to make sure we're all on the same page. So we're going to talk today about palliative care. Palliative care is care for patients with serious illness. The purpose of palliative care is to address needs of the patient and caregiver in physical, psychological, social, functional, spiritual, all of the domains of life. It is not just physical. Nurses give holistic nursing care, right? When we're providing palliative care, we're caring to those holistic needs of the patient. So we call palliative care, it's patient-centered. Everything we do should be driven by the patient's values, beliefs, preferences, and their goals. But we also consider palliative care to be family-focused. It's patients at the center, but we're also going to focus on the families, because the family's going through something here too. Now, if you hear me say the word primary palliative care, this is what I'm asking of all of you. This is going to be the expectation of a nurse who's working at the bedside, not a specialist. We do have specialty palliative care. We have people specifically trained in palliative care, who their role is when we've got complicated symptoms, we've got complicated social or spiritual or psychological things that we are struggling to manage within our normal team, we can refer them to these specialists who are trained to give that higher level of specialty care. But there's a lot that you as a nurse can do to improve the quality of life of somebody who's got a serious illness. This is not I ain't doing it. This is so much of what we can do. So what is a serious illness? What we're going to be focusing on today, serious illness has 3 things. First, it is something that has a high risk of mortality. By the very nature of being diagnosed with this illness, you now have a life expectancy put on you. Your timeline has changed. It could be years, it could be months, but all of a sudden, instead of a question mark for when will you die, now there's a time frame. That's what we mean by high risk of mortality. But not only that, palliative care, where the serious illness cares, but not only do you have that life-limiting illness, but it's now adversely impacting your quality of life. You are not, that person's quality of life is not at the level that they want it to be. Or it could be where the caregiver is experiencing very heavy strains from the caregiving. So it's not just, again, we're family focused, so it could be that the patient is experiencing distress or the caregiver. Now, hospice is a whole other thing. Please know, palliative care and hospice are not the same. And if you do not learn nothing else, I want y'all to be the one debunking that. So many nurses think it's the same. I have my sister-in-law is going through where we're trying to get her dad into palliative care because he's got end-stage MS. It's awful. And the other sister-in-law, who's a nurse, is like, but he's not dying. It's not the same thing. I'll smack her. So, it's not the same. This is not hospice care. Palliative care starts the minute that you're diagnosed with that serious illness. Hospice has criteria. Hospice is 2 physicians have independently assessed this patient and said, yes, I would not be surprised if they were dead in 6 months. Does that mean they have to die in 6 months? No, people can live for a very long time on hospice, but Yes, it would, given the state of this disease, we would not be surprised if this person died in 6 months. That's the criteria from the healthcare provider perspective. It's one question, and if the answer is yes, I would not be surprised. They qualify. But then there's the patient conversation side. To be eligible for hospice, that person has to be willing to stop disease-modifying treatment. So if you have cancer, you stop the chemo. Now, if you have heart failure, it doesn't mean you stop your beta blockers and you stop your diuretic. We're not going to make the symptoms worse. But if we're doing treatment to try to cure, that's what we stop. Okay? The other piece, and there's another slide later, there's more elements and we'll dive into that. So when we talk end of life care, now we're in those last weeks, hours, days of life. That person is in an actively dying stage. We are now seeing organ failure begin, okay? So, you're going to hear me throw those terms out. I just want to make sure we know what we're talking about. So, one of the things, again, people are like, okay, yeah, it's nice. I mean, it drives me nuts. These are the things they do. Yeah, well, palliative care is nice to have. Okay, there have been lots of organizations who have said that access to palliative care for a person with serious illness is a fundamental, basic human right. Patients who have serious illness have a right to have their quality of life maximized. They have a right to not be forced to suffer. So people are like, oh, I don't need to worry about it. No, but in honoring your nursing code of ethics, you have a duty to help patients to avoid suffering. So in that vein, palliative care is, in essence, a human right. We've seen this more than ever with the pandemic. So many people are struggling with, I don't know what to do at the bedside of somebody who's dying. I don't know what to say. I don't know what to do. I don't know how to make their life, their dying process go well, but it's a right. Now, there's a whole lot to the statement. But one of the things that these organizations say, when they say this is a mandate of a human right, one of the things is education. That healthcare providers have to be educated in how to do this well for patients to have access. So you are a point of access for patients to improve their quality of life, even now. Now, am I asking y'all to do payment stuff and help? No, don't go you don't have to go to the legislature. You can't afford to. But I'm talking about we're going to focus on education today. So what are the philosophy? What are those tenets of palliative care? It's at any stage. Have y'all seen this image before? Probably not. I get all excited about this. Okay, so the minute somebody's diagnosed with a serious illness, they can be eligible to receive palliative care. Not specialty. They're eligible to receive care that's focused on improving their quality of life. And we can give that supportive care alongside curative treatment. They can be getting the surgeries and the aggressive interventions. They can be doing anything they want to try to fix the illness. We're just there walking alongside them in that journey to help improve their quality of life. If they're having issues with uncontrolled pain, we're going to step in to try to make sure we maximize pain management. So that's palliative care. Once we switch gears to a 6-month timeline and the patient meets some other criteria, now we're in hospice. At that point of death, our care for the patient doesn't end. We care for that body even at death. We respect that patient until they're out of our care. But then we continue and we support families through the grieving process. By the way, you're not doing this by yourself. This is a team approach. This is using those daily huddles in a very intentional way to be like, what is concerning to the patient? What is going on? Like, hey, this person is really short of breath. We've got to do something because the dyspnea is really bothersome to them and it's impairing their breathing, it's impairing their quality of life. We've got to do something. I'll be like, whatever. Okay? So it's for anybody. This could be anybody from the 1-day-old newborn all the way to the however old the person wants to be. Everybody can get palliative care. We give this in any place that we are caring for a patient. It's outpatient, it's inpatient, it's in community settings. It's anywhere where caregiving is occurring. Y'all are going to be sick of me saying it, but it's all about the goals of care. One of the things that steps people wrong in doing this work is this what the provider's like, this is what I want to do. Okay, great. What does the patient want? What is the patient's end outcome goal? We've got to keep that in mind. I was talking with an oncologist one day. Oh man, I wanted to smack him too. I'm very violent in my head. I'm not outwardly violent, but there's some of those smack people. He was wanting to figure out how he could build a tool to be more effective in communicating prognosis to patients. Okay, let's talk about it. He's like, all right, well, I want to tell them how long they have to live, and then I want to tell them what treatments we can do. I said, okay, well, you're missing this step where you ask them what their goals are. You ask them what's important to them. He's like, yeah, I don't have time for that. I just want to get to what I'm going to do. I was like, yeah, I don't think we can work together if that's going to be your thing. Let's talk about this, because maybe the patient says, here's my goal. Half of your treatments aren't even something we should talk about. So we have to know the goals. We have to always keep that in mind. As we get further along this trajectory, and not even toward the end, we want to start preparing patients and families for death. Again, serious life-limiting illness. We want them thinking about what would they want their death to be like. Where would they want to be? Who do they want to be? Now, not the same day they got diagnosed, right? But there's going to be points of contact with that patient and their healthcare team where maybe they're having a good day, maybe their symptoms are a little bit better controlled. Maybe we could start putting the questions, asking them, what would your thoughts be about this? And get them thinking about it. So when we talk about this holistic care, I want you thinking these 4 domains. Now this is the quality of life model that actually my mentor made this years ago, and I love it. Originally derived from cancer survivorship, but this applies to anybody with serious illness. So when we're thinking about a person's physical well-being, it's about pain, it's about symptom management, it's about their sleep, their functional ability. Concerns about fertility might be very real, especially in patients who are in their late teens, 20s, 30s. So what are their concerns about reproduction? Psychological well-being is very tied to physical, but this is, again, the anxiety, the depression, what brings enjoyment? What are your fears? There's a lot of fears in palliative care that we have to talk with. Then we want to think about the social. How do we support their social well-being? How do we help them actualize engagements in their roles and responsibilities as best they can? And then spiritual. Have y'all learned, like, nurses have a role in helping patients in spiritual distress and tending to spiritual needs? That is not just the chaplain's job. Okay, so I said we'd talk more about it. So what are the similarities and differences? Y'all are going to have to know this. Hint, hint, wink, wink. I don't think I can tell you to start it anymore. You've got to know the differences. So again, we said hospice care. 2 physicians have said we would not be surprised if this patient was dead in 6 months based on the current disease state. After they are enrolled in hospice, it just takes one provider on a monthly basis. It can be an advanced practice nurse. Say, yep, still could be 6 months. The nice thing is that there's more services formally offered to patients who are in hospice because Medicaid and Medicare will reimburse for those. We offer in clinical settings or wherever the patient calls home. It might be in their home, it might be in a long-term care facility, it could be anywhere that they want to call home. But the 2 criteria that have to be met from the patient side to be enrolled in hospice is 1, they have to stop the disease-modifying treatment. If they've been trying to cure the cancer with chemo, they've got to stop the chemo. Now they can still take all the medications they need to for pain. For if they, again, heart failure, we're going to let them take all those medications to keep, cardiac output going as best we can to prevent that edema from building up. If they've got COPD, we're going to keep them on all of their bronchodilators and all their medications to keep their airways as open as they can. We're just not going to do those disease modifying, those things that are intended to cure the underlying problem. The other piece of it is they have to agree to not go to the hospital if they have an exacerbation of that illness. So if the person starts going downhill and they're, oh my gosh, it looks like they're dying, you've got, okay, we're at that point. Now, if they fall and they break their hip, they can go to the hospital and get treated for that. It's, you don't go to the hospital for the disease that has the life-limiting part to it. Now, people can discharge out of hospice at any time. It is very frequent. We're in like adult 2, right? We're talking about acute care. It is very frequent that we will see patients who, like the family member, all of a sudden that person's starting to go downhill a little bit. They're starting to see the signs of the patient's conditions worsening. They want to call the ambulance. They want to get that person to the hospital. They will call hospice and say, we're done. Bam, they're discharged. They can go on to the hospital. There's no reason that they can't. They have every right to say, I'm done with hospice. I want to go to the hospital. We want to deal with this. Now, hopefully throughout the process of being with them, we've helped them think about how would you handle that? What would you do? But you might see people in the ER who's like, they've been on hospice, but we just stopped. Well, because they wanted them to seek the care. And that's okay. Can they get through the hospitalization and call hospice and say, we want to come back in? Sure. We're never going to deny the person that if they meet criteria. So palliative care, again, any point, there's no timeline here. You can do your disease-modifying treatment. A lot of times this is going to be in clinical settings where we're doing things with the patient to optimize quality of life in the moment. The downside is insurance hasn't bought into this as much. But we actually have done a lot of research and we see that when we understand patients' goals, and when we align our medical and our nursing plan of care with those patients' goals, we typically avoid spending all of this extra expense on things that the patient doesn't really want. So when we align the care accordingly, we actually save the healthcare system money. So most healthcare systems have realized, man, if we have specialty, and like we get patients' pain under control, we get patients' symptoms under control, they don't come back to the ER as often. There's a way to save money. So a lot of times hospitals will pay for it outright because it saves them money. And you know hospital systems, the big system, they're all about saving money, right? Now both of them, these are patients with serious illness. We're going to focus on the patient and the family. We're going to work with our team. We really want early referrals. It makes my heart so sad when I hear patients have been suffering for 6 or 7 months. Nobody was doing anything. And now they're getting into specialty services, and then, oh, I feel better. I wish this would have happened forever. Well, yeah, I wish so too. We want to focus on advanced care planning. We're going to talk a lot about that here in a little bit. But again, they can stop any service at any time. All right? So what are some of those benefits? If we are being very mindful of our role is to help improve that patient's quality of life and align the goal of care with their goals, or their plan of care with their goals from the beginning. What do we see happen? Well, they have improved quality of life. That's the whole purpose, right? We're trying to focus on making their life better. We reduce the symptom burden. We reduce their suffering. We decrease their costs. The caregivers get the support they need so they're not overstressed and like feeling like I'm all alone in this. Think about those dementia caregivers. 24/7, nonstop care. If no one's helping them out, it's going to negatively affect their health as well. And we get improved satisfaction. People they're heard. They don't have things done to them. They're doing things with their healthcare team towards a mutual goal. So just kind of making it like, why am I being so harping on this? Well, we know that each year there's 40 million people in the world who need palliative care. But we also know that 86% of those 40 million people are living with uncontrolled pain and symptoms and are suffering because they're not getting palliative care. And of that, a huge population is children. And remember, this is concurrent with disease-modifying treatment. There's no way, no reason we have to have these little kids suffer. And one of the big reasons that we see this is because the healthcare workforce isn't well educated on this. We're going to fix that today. And what I want you to do is take what you learned today. When you're at the bedside, start trying to implement some of this. But also when you see a healthcare provider doing something, you're like, ooh, that is not right. See if there's a way you could like talk with them about that. Maybe do some informal education. So what is your role? So okay, I've gone about what is it. You're like, that's all great and grand and like kumbaya, woohoo. Here are the things that you are going to do that can improve the quality of life for your patient. Best thing you can do is just shut up and listen. How many times do we see where like someone goes in the room, here's what we're going to do, here's your side effects, your medicine, okay, bye. Do you need anything? Bye. How many times have you just like paused and just said, hey, how are you feeling today? And just sit there and listen. Hopefully maybe you're doing that now, but now they're like adding how many more patients do y'all? You're out, I don't know, how many patients? It depends. Y'all are caring for people right now, right? So, 2-ish, okay. But foundations, y'all were like, hey, hi, about 1, maybe a lot. But listening, this is your number one thing. If you don't know what to say, shut up and listen. Let them talk. Let them tell you what they're feeling. Let them tell you what they're worried about. Have y'all heard of this term of presence? Just being fully with them. So putting the phone away, putting the to-do list aside, taking some time where that patient is your whole entire center of your focus. Doesn't mean you have to say a bunch of stuff that you're there. Okay, that's bearing witness. You're just being there with them, hearing their story, hearing their experience. What else do I expect you to do? Do those holistic assessments. It's not just what you're paying on a scale of 1 to 10. It's also seeing, do we have concerns that there's maybe some anxiety or depression? Are we hearing something about maybe they've got some spiritual distress? Are they telling us that they're really worried about how they're going to pay for their medications, or they're not quite sure how their family's going to get food on the table? Are we doing something about that, or are we just saying, sucks to be you? We're going to work with the team. This is not something you do by yourself, but when you're the ones there, right? Hopefully all the nurses are the ones there at the most. When the patient raises your awareness of a concern, we take that to the team, and the team should figure out what we're going to do about it. We don't just ignore it. So you're going to advocate. With the patient saying they want this and the team's not listening, you got to remind them, no, this is what the patient wants. We're going to develop the plan of care knowing what the patient wants and trying to do our best to meet those expectations. And the thing to know as well is as we get into serious illness care, we get into end of life specifically, there are a lot of cultural rituals, a lot of cultural practices and beliefs that we have to be mindful of. You probably heard this term like cultural competence. I think that word's stupid. I don't know if anyone else. I personally cannot be competent in everybody's culture. But I can be culturally sensitive. I can be aware that each person has their own beliefs and their own culture. And people are an amalgamation of different cultures, right? It's like I'm not just a white person. I have a lot of different things that inform who I am culturally. So being culturally sensitive is saying, I don't know what you need. I don't know what your expectations are, but I'm going to ask. I'm going to try to do my best to honor that in the care that I give. Another important thing is prepare the family for death. Do not wait till a sign manifests. We want to let them know ahead of time, we might be seeing this. We're getting to a point where now we might start to see organs to stop. We might see their legs start getting pulled. Don't let the family get scared because what does this mean? Oh, I knew that was coming. Let them know. Come on. So what does this mean in the critical care environments? Because that's where we're in, right? We're talking about acute care and critical care. One of the things in the hospital, we've got to do a better job of getting patients plugged into hospice sooner. If they're done wanting to pursue disease-modifying treatment, if they're just like, I'm so over this, what we see right now is most people get into hospice the last week of life. That's 5 months and 3 weeks of improved quality of life that they were not provided. So we want to try to get them in sooner. We do know that culturally there's a major disparity. We see the majority of hospice patients are white people. We've got to fix that. Every demographic has serious illness. Every person has a right to palliative and hospice care. We need to make sure we're being much more equitable in how we're referring, how we're communicating to these individuals, and getting them access to services. Another big thing you're going to hear is that providers are afraid to bring up hospice because they feel like, well, if I bring up hospice, this means I failed in my job. I didn't save them. I didn't cure them. Okay, everybody does. everybody dies, okay? Now, we're not going to get existential about this, okay? But everybody's going to get to a point in their life where their disease trajectory is going to decrease and they're going to get to this phase. So it's not a failure, it's that the body the disease did what it did, the patient's life has taken the course that it did. Denying that and trying to, no, keep going. There's a lot of times it's very provider driven, like I know I can fix this. What does the patient want? I had a people, how am I getting down? I was like, this person made me mad because it drove me nuts. This is why I got all into this. Had a patient who had end-stage liver disease, end-stage COPD, was on dialysis, had a cardiac arrest at home, was on hospice when that happened, but the family was not, when they weren't happy, they were like, no, so they discharged out of hospice, called 911. Again, they had every right to do that. Patient gets up to the ICU with me and the doctor's like, let's do a thoracentesis, he's got fluid on that, let's do a paracentesis, let's put him on hypothermia, let's do this. We just have a moment here. You have a lot of toys you want to play with right now. Have you even talked to that family member? Well, no. Okay, the patient's unconscious. Have you talked to the family member? Do they want you stabbing needles in 6 different places just because you can? Whoa. So I went out and talked to him. Hey, can you come back here? We want to talk. We want to know where do you want us to go with this? And the minute we paused and I said, stop playing with your toys, and we talked to them, he's like, no, I don't want my dad to have all of these things done to him. Okay, well, if we don't do that, then the progress, that disease process, that death that was occurring is going to continue. And that might be what the result is. That's fine, but do not stab needles into him. And we didn't, and he died. But he died way better than he did had we been doing thoracentesis and paracentesis and shoving tubes in all these different places that he did not want, that the family didn't want. So it's about asking questions and knowing the goal. And with that, I'm going to check into my flight. So let's take a 10-minute break, take some big breaths, get some sunshine. I know this is a very heavy topic today, and then come back. So, let's get into this a little more. So what are those common diagnoses? These are people who, when we think serious illness, okay, cancer, this is where hospice originated. Hospice was born out of cancer care. But we also, heart disease. Now, not stage 1, right? We're talking end stage. We're in that end stage heart failure. It's typically going to have a lot of symptom burden, but it can be earlier stages. It's all about quality of life. If they have symptoms that are distressing, we need to help address that. Dementia is huge in this world. Respiratory disease, your COPDs, emphysemas, chronic bronchitis, all those chronic respiratory illnesses. Stroke can be one, especially when we have a lot of impairment. Chronic kidney disease. I will tell you, when it comes to ethical issues, dialysis abounds because there's 2 rules of thought. A lot of people say, well, dialysis, we're just symptom management, right? We know there's a lot of symptoms that comes with hyperuricemia and hyperkalemia. Insurance considers it a disease-modifying treatment. So the nephrologists really struggle with this because they might want to enroll their patients in hospice, but insurance says then they have to stop dialysis. Well, what do we know about stopping dialysis? They're going to die within a few days. So major ethical issues. But they definitely can have palliative care from the get-go. So what are the characteristics? Those nurses who are good at palliative care, what do? They're good at teaching patients. We got to educate people about what's going on, help them understand their disease, help them understand how they can maximize their self-care. Compassion's huge. This is something that I think we're seeing a lot of. I'm sure a lot of y'all see nurses who are in compassion fatigue, burnout, where they're just like, I can't give a crap anymore, right? Compassion's huge here. Flexibility, understanding that the plan of care needs to change fairly frequently. We need to adapt to where that patient is. Understanding that their goals might change at any time. They might have questions that they need to have answered. We're culturally sensitive, adaptable. There are so many misunderstandings. There's a lot of misunderstandings. Y'all might have some things you're trying to sort out from this. What does this mean? What is this? Team members, there are going to be people who are very not aligned with this. They don't understand it. clarifying is good. Y'all know you have, like, as students, you can teach the providers. It's good just to like raise questions like, okay, well, we learned that this was this, so I'm just curious on how you're doing that here. Right? You can teach through asking questions. So the general public also, they hear palliative care, they think, okay, you want me to die? You're done caring for me? Nope. And again, like people who are thinking about hospice are like, well, if they don't die in 6 months, does that mean that you're done caring for them? No, we have people who are in hospice for 3 years, 4 years, but they still have a prognosis where the yes question is answered. A lot of times we see that people who get into hospice early actually live longer because we're not allowing that symptom burden to increase. So these are some statistics that have been published by the National Hospice and Palliative Care Organization. I just think it's helpful. It's like, do not worry about memorizing these numbers, y'all. Okay, this is just to prove a point. So I mentioned earlier that we have a huge disparity in access that, as you can see, in 2018, they reported in 2020, 82% of patients in hospice were white. We are not doing a good job in our healthcare system if there's that huge of a disparity in access. Now, there's cultural elements to this. How different individuals, what they believe the meaning of death is, what they believe the meaning of illness, their approaches to end of life. Okay, we're going to respect that, but it's also about helping them understand what the benefits are. And that we're not going to ask them to like abandon their beliefs if we access these services. Yes?
These numbers are not adjusted for the percentage of population, so the disparity is still there. It's not being as great as made up with the census shows that white people are 76% of the population. So there's still a disparity.
Right. So this was a Medicaid and Medicare patient. So this is what that's at. So yes, there is even like, but they did try to actually, in this, they are adjusted for, like they're weighted according to kind of the distribution and the demographics. So it does account for that. Yeah, because there is that. There is like a need in research to not oversample, undersample, but there is still a disparity. The other big thing here is, again, the bigger percentage of patients who died in hospice were only in there for a week. So the healthcare team waited till, all right, we've done everything we think we want to do or can do, and now we're going to offer this service, where we could have done it much sooner. What else do we know? So we know that over half of patients were in hospice for less than 30 days. So again, we could do better jobs of identifying patients who might benefit. Now we understand the big thing is you have to stop disease-modifying treatment. If a person doesn't want to, they don't have to. So that doesn't mean that because somebody might be in the last 6 months of life that we're going to force them into hospice, right? We're going to align with their plan of care or their goal of care. Okay, so now let's talk about what your responsibility is when it comes to grief. This is the hard part. This is where you have to step out of the pathophysiological world of nursing and get to the human side. And this is where we feel like we falter the most. We're like, I do not know what to say. How many of you have been at the bedside, the patient's crying or family member's crying or somebody's angry, you're like, I'm just gonna step out of the room, right? We don't really always know what to do. It's okay, but let's try to figure out some things we could do. So some key terms here. Loss is when something's gone. A person, a belonging. A loss is the absence of a thing that was there. It can be actual, so a person was lost, an object was lost. This is not, I lost my cell phone, right? But that would be a loss for some people. I think there's catastrophic loss for some teenagers, I feel like. Or it's perceived, that something that held value for that person is no longer there. So this might be like when they lost a job, but they also feel a loss of identity. Grief is that emotional response. That's what we are responding to. We're not responding to a loss, we're responding to grief, which is very personalized. Each person's going to experience it differently. Grief is what has that emotional component. Now bereavement, you saw it in that diagram, there's this bereavement. It's a period of time after that loss where we expect grief and mourning to occur. So grief is that emotional component, and mourning is what we as healthcare providers can see. It's that outward expression. And again, huge cultural components to this. Extremely individualized. So there's never going to be a normal. You'll hear, oh, this is normal grief. For who? Everybody's going to have a very different experience. So there's all types, and your book says normal, and that just drives me nuts because again, it's not normal, but there are some things that typically we can see. Anticipatory grief. This is huge in palliative care. Patients who've just been told that they have cancer, patients who have just been told that they have end-stage liver disease, kidney disease, whatever. Now they've been told you have a life expectancy. Anticipatory grief is the grief that comes from knowing that a loss has occurred. They might be having to prepare for multiple losses. Well, what does it mean when I can no longer work? What does it mean when I can no longer take care of my family? What does it mean when I lose this? What does it mean when I can no longer walk or feed myself? Preparing for those losses, and there's grieving associated with that.
I'm sorry, did you say that grief is known and loss is further happening?
At least you have now with
So, this slide before? No, anticipatory. Anticipatory grief is when you are anticipating, you know a loss is coming, and there's grief associated with that, right? Like, I know at some point, like, think about people who have that ALS, right, that SMA paralysis. I know there's going to be a day where I can no longer swallow. I know there's going to be a day where I can no longer breathe. And that's scary. And that can involve a lot of emotions. We can see acute grief. This is from traumas. When there was somebody who had no life expectancy timeline, something happened, something catastrophic occurred, and a life was lost. You have probably seen this, those of you in the emergency room, right? Motor vehicle accidents, violence, traumas. I was in Alabama, tornadoes. we would have deaths from tornadoes. So chronic grief is grief that lasts a longer time. This is something we might, it might be okay. We just want to keep an eye on these people because there can be a point of time where we need them to kind of re-engage with society. We want to kind of support them to getting back into, not a normal, right, but just back into routine. And it might take some people longer, and that's okay. It might be adaptive, that they're just using some different strategies to try to cope, and it's more incremental, and that's okay. We also see delayed grief, where there's this period of kind of shock, or just like, I can't recognize, I can't acknowledge it. And then we see the grief occur a little later, and that's okay too. For a long grief disorder, this is where we're really going to start wanting to have to do some, we want to start checking in on this caregiver, this family member. This is where the behaviors we're seeing are concerning. They're completely, they're not engaging in socials. They're not caring for themselves anymore. They're just letting kind of their life fall apart around them. This is somebody we want to intervene. We want to get them into some psychological support because we don't want the grief to become so all-consuming that they then now are not living and functioning. And another thing that type of grief that I think is really important that we think about is this disenfranchised grief. We see this a lot in populations, but it's, I'm not articulating this well, I'm sorry. Disenfranchised grief is where that grief is not recognized. I took care of a patient so many years ago, and actually with my students, but it was a transgender patient who died. And it drove me nuts because the transgender patient had not been engaged with the biological family, the family of origin, ever since she shared her identity. The family disowned her. But the mom was the decision maker. And because the mom didn't agree or didn't believe, she kept calling the patient, that's my son. Well, that's not how that person identified. Not only that, the mom would not allow any of the person's chosen family to come to the bedside to grieve, to be there. But those heathens have no right to be at this bedside. They're what made my son have a falling out with God. It was a whole big thing. And it was really difficult because that entire chosen family was not even recognized as some people who were grieving. Because the mom said no, and the mom was the legal decision maker, ethically, legally, our hands were tied. We could share nothing, right? Because we know all about HIPAA, right? We can't share information unless we're given permission to do so. We weren't given permission to do so. So very, very distressing for me, but that entire chosen family was left with disenfranchised, unrecognized grief. We see this a lot when we have same-sex partners. People can let their personal beliefs about that interfere with recognizing that that person had a loss. We can see this with grandparents. Like, well, the parents should be the ones who are sad. Yeah, but that grandparent has not only had a loss of their grandchild, but now they're also watching their child be suffering and grieving. So it's making us think about who in this social network has experienced this loss. Because again, it's not just about the patient, we're thinking about the family and caregivers. And it's not us saying we've got to fix every single person and help every single person in their grief, but maybe we need to connect them to support groups. Maybe we need to plug them into some community resources to help them in this period of bereavement. So we need, again, respect that there's cultural differences. We never know how it's going to be because it's unique, and we just need to be kind of on the mind, or kind of on the, just watching for this. Okay. Did y'all learn the stages of grief? Let's talk about it. There's 5 stages. So what I want to talk about is what's wrong about that and what the truth is. Because people are like, all right, there's these 5 stages, and you start with denial, and eventually you get to acceptance, and then you're back to life the way it was. No. The person who made this grief model, Kubler-Ross, actually never meant for it to be interpreted the way that people ended up interpreting it. So what it does mean is that there are these 5 stages. People might experience denial, they might experience anger in their grief, they might be bargaining, well, if I do this, maybe this can happen. They might experience some depression, or get to a point of acceptance. But this is not linear. People can go back and forth, people can repeat these different stages. They don't have to go through everything. Some people never get angry, and that's okay. We don't have to follow these, right? Like, it's like you don't have to start in denial. You can start in anger. You can start in bargaining. You can start anywhere you want. Not only that, as again, she was like, here's some main terms, but like you can experience other emotions, and that's okay too. That doesn't mean that person's grieving wrong. There's lots of other emotional experiences that a patient can have. And then recently there's been a 6th stage added in finding meaning. So finding the meaning in the loss, kind of doing some more deeper exploration of the grief. So we think nursing process, what's the nurse's role in assessment? Assessing the patient, again, is there anticipatory grief? Assessing the family caregiver, when that loss occurs, not abandoning them and saying, peace out, I've got to go do post-mortem care. What can you do? You can just be there. When people are in grief, when people are mourning, they're showing those outward things. A lot of times they're like, I don't know what to say to make this better. It's not your job to make it better. It's your job to acknowledge that they're grieving and just be there. So just listen. A lot of open-ended questions. This is basic therapeutic communication, right? Something that can be helpful, again, knowing their goals, their preferences, but also their hopes. A lot of times people will say, well, there's no more hope. We can always find hope. We can redefine hope. Maybe we can't hope for a cure anymore, but maybe we can hope for that there's no pain in we have good pain control. Maybe we can hope to get to somebody's graduation in a couple weeks. Maybe we can hope for something. So when people feel hopeless, sometimes it's helpful to kind of reframe and be like, yes, that's very difficult, and yes, that loss has occurred. But let's try to see if we can think of something to hope for. That we can't hope for, but what else could we? Okay. Again, we're going to look for those nonverbal cues, because people are not always going to want to share that grief verbally, so we want to be cued into those nonverbal cues, and if we should have some concerns, ask open-ended questions. If you're like, I'm seeing something and I have no idea what to say, get your team members involved. Maybe you need a chaplain to come to the bedside. Maybe a social worker needs to come. There are times where you are the right person, and there are times where you are not the right person. And it's okay. If you're like, this family and I aren't jiving, then you should be the one having these deep conversations. Get somebody else in there. And think across all those domains. It's not just what's your physical pain. Let's think about all of those domains. I'm going to show you all a little video about presence, because I think it's awesome. This is my mentor, Betty Farrell. She's amazing, but I just want you to hear about how presence can work and some things you could do when you don't know what to say. connecting with the patient, asking questions. We can provide assurance to patients who are grieving. Now, not that it's all going to be okay. You have no way of knowing. But assurance that they're not going to journey through this alone, right? They've got somebody with them through this. Even in acute care settings, right? That you're going to be with them through this shift, right? That you're not, if they need you, they can hit the call button. Somebody can come. So one of the things she talked about is storytelling. That's a huge thing. If you've got people who, are really struggling, you're taking care of older patients, ask them about their, especially dementia patients. This is a huge helpful strategy. They don't remember recent, but they remember long-term. So sometimes asking them about, what did you do for a living, or where did you grow up, or things like that can help them reminisce and can be very soul-fulfilling, I guess, experience for them. So a lot of times asking patients, showing interest in them can be very helpful. So thinking about nursing process, well, how are we going to plan and implement? What are we going to do? We're going to provide a supportive environment. If somebody's grieving, provide privacy. Nothing frustrates me more than when a family member has maybe been told that their loved one has just died and they're having to stand at the nurse's station or they're out in the waiting room. Can we think about where we have these people when we give some difficult news? Giving them a place where they can be, have not the eyes like, ooh, what are they upset about, right? Giving them some privacy. If somebody's, emotional and crying, not being like, okay, not privacy where it's like, I'm going to leave you to that and I'm going to be back, right? But providing privacy, honoring wishes as much as we can. Again, making sure we're patient-centered. What are the goals? One of the things you can do if you're not sure what to do, you're like, this family's like, especially in that dying process, the family is, the patient's dying, the family's accepted, this is what, that we're going to let this person die. And then it's this awkward time of what do we do? One of the things you can do is offer some practical help. Not like, is there anything I can do for you? But it's like, I noticed that you haven't had any water today. Could I bring you a glass of water? Or, do you need, I haven't seen you take a break and go to the restroom. I can stay in here and be with them for a few minutes if you just need to go to the restroom. Right, so kind of being mindful of what might their physiologic needs be, what might they need at that moment, and offering to kind of take a step in and help for a second. Being honest. Now keep in mind your scope of practice. If they haven't been told they have a bad prognosis, it is not your scope of practice to drop that bomb, right? But we want to be honest with people. If you don't know, it's okay to say you don't know. You want to listen. Again, make sure we keep that family involved and refer to bereavement services if we can. So here's a list of some things not to say. Okay? Don't ever say you know or you understand. I know how you feel. What do we know about grief? It's unique. You can never know exactly how they feel. You could appreciate, or I recognize if you're, you seem obsessed or distressed about this. Don't ever say, well, it was their time, or their higher power needed them. We want to make sure we acknowledge that they had a loss. We don't want to try to rationalize away that loss. What are some things that we know I've heard that are just painful things? At least you have your children. Yeah, you just lost your spouse, but you've got your kids. Women who've miscarried, one of the worst things you can say to them is, you can always have more babies. Does that acknowledge that baby they lost? No. Someone who loses a spouse saying, you're young, you can find somebody else. People say this. They try to rationalize, it's going to be okay because here's what you can do down the line. You need to allow that loss to be felt. So let's dive into some ethics. Acute care, the world of ethical landmines. Let's talk about some of these things you're going to see. What are some issues in our emergency department, critical care? There's so much unpredictability. People who are critically unstable, we don't know how they're going to go from one second to the next, right? So being able to very clearly say, this is how this is going to go, is not possible. It's a guessing game. Sometimes it can be hard to figure out when patients are nearing the end of life, and sometimes people progress to death very quickly. We know it's very fast-paced. We have lots of technology at our fingertips that we can try We could do this, we could do this, we could do this. Yes, but is that appropriate? Patients who are on sedation medications, or maybe they're mechanically ventilated, or they're on paralytics, can they communicate with you? No. Makes it hard to know, are they in pain? Are they experiencing uncontrolled symptoms when they can't communicate? Nothing's harder as a nurse than when a patient has come into the hospital unresponsive. We're doing these aggressive treatments, and when we try to figure out what were the patient's wishes, nobody knows. No, we don't like to talk about death in our culture, right? So a lot of times we don't like to ask, well, what would you want to happen if you died? Not a bad question to ask family members early, even before they have a serious illness. Hey, if something happened to you, what would you want? Y'all can go home today, ask your parents, be like, what are you learning in nursing school? Totally blame me. But it's so hard when they're like, I don't know. Well, based on what you knew was important, then what do you think they would want? That is a hard question to ask. There's a huge focus in acute care settings to do everything, to cure, to fix. And when we can't do, cure, fix, we feel like it's a failure. Death is seen as a failure. No, death is an inevitability of life. And death can be good when we allow somebody to die without pain and suffering. So what are some things? Advanced care planning. This is going to come up in leadership and management, by the way. Dr. Stoltz asked me to throw this in. So let's talk about this. So advanced care planning. In ahead of time, thinking about preferences. Sharing those with people. Sharing them with the decision makers in your life is important. But also documenting them. We have got to have preferences documented. I think one of the coolest things that you could do is have like an advanced directives party, advanced care plan party. Everybody's going to get together, think about what they want, write it down. You have to have 2 witnesses who are unrelated to you. So it's like, hey, lab partners unrelated to me, here's what I want, be my witnesses. I've had students do that. I've had little students do some advanced care planning parties. Let's all get it written down. You can do it at a family thing, but you have to have like non-family members there to witness. Okay? You can always change your mind. You can always change what you want. But if you change your mind, you got to update documentation too as best as you can. Or make sure it's known. If you change your mind, make sure people know. We can't ask people right on the spot, tell us what you want. We're going to have to give time for them to think. That's why thinking ahead of time is great, because you can think about all those potentialities. I'm all cool with the vet for a few days, but if I don't have a chance, please don't shove a thing down my throat. I thought about it. Some things to consider is that there's different documentation for resuscitation preferences out of hospital versus in hospital. We can also document the type of interventions that you want in different places. And also a lot of the legal documents are going to ask what their preferences are for nutrition and hydration. So in Texas, now I want to be very clear. What I have pulled is the advanced directive documentation in the state of Texas. Every state is very different in the documentation. It's all essentially the same thing, but what they call it, the requirements for making them legal are different. So some things that are very critical that we have is the medical power of attorney. This names who is your decision maker. These are very helpful to have. I once had a patient who was estranged from his wife for like 10 years, but he never had a medical power of attorney. So when he became in a state where he was unresponsive, legally the next of kin was the wife. Didn't matter that they were estranged for 10 years. She was still technically his legal wife. So guess who made decisions? There were times I questioned. We did have an ethics council on this, like, okay, she hates this man. Can she really be his decision maker? And they said, yep, she can, but we're going to keep an eye on decisions. If it looks like she's gunning for the life insurance, we're going to have a conversation. But write it down. If you don't want your ex to do it, write down who you want. If you've got a family member who you know is going to want to do everything, and you don't want to do everything, don't let them be your decision makers. Pick somebody, it doesn't have to be them, pick somebody who you know knows what you want and will stick by what you want. Here's the thing, though, we have to have it accessible. It needs to be notarized or 2 witnesses, but you have to have it handy. You got to be able to present it to the healthcare team. You can't just say, I have the power of attorney. Great, prove it. A living will is where you document all the preferences. Do you want to test compressions? Do you want artificial nutrition? Again, also has to be accessible. An out-of-hospital DNR means that if that person has experiences cardiac or respiratory arrest out of the hospital, that they do not get CPR. I have patients who sign these out-of-hospital DNRs, and by gum, they do not want CPR. They will take this to their front door. I kid you not, they take their out-of-hospital DNR to the front door, so if somebody calls and EMS arrives, it is right there. Let me go. Has to be accessible. Out-of-hospital DNRs do require physician's signature. The physician does need to know that that request has been made. Texas also has what's called a MOST form. You might hear PULSE or MOLST. There's all these different abbreviations, but a MOST form is from the physician. This is where a patient has verbalized to the physician what they want. This is basically an order set. It's not a legal document, it's an order set. That the physician can write the order set for here's what the patient's told me they want for their end-of-life wishes. Do they want full code? Do they want comfort measures? Do they want nutrition? And then that follows the patient if they're like, if they're transferring from one unit to the other, if they're transferring from one facility to the other. But this comes from the physician. So if the patient can share their preferences, but we don't have some of these other forms, the physician can create this order set. All right, let's talk ethics. Assisted death. Okay, so euthanasia is not legal. Euthanasia is not permitted by the American Nursing Association scope of practice. You cannot take a step to end a person's life intentionally. That is not allowed. Now, y'all might have heard of physician-assisted suicide. The more medical appropriate term is medical aid in dying. This is not euthanasia. This varies by state. Texas is not a state that permits this. But some of you might want to go to states where this is permissible. This is that patient making the decision. Euthanasia is you deciding, I'm done. Let's kill that person. Can't do that. In medical aid in dying, this is when a terminally ill patient, they have to have a terminal illness. They have voluntarily stated that they want to, that they're done, right? They want to they are choosing to end their life or to hasten death. They're fully autonomous when they make this decision. And the caveat is they have to take the medication. You as a healthcare provider can never give that medication. There's some great documentaries about this. If you're curious, there was a man who, before it was legal in the States, went to a European country. He had ALS. He knew he was dying. He was getting to the point where he was about to experience respiratory failure. He was so short of breath. He could still swallow. He could still raise a cup to his mouth. And he knew he had to do it then, because the minute he could no longer give that medication to himself, he could no longer do this. So they have to be able to, nobody else can give them the medication, right? A physician can write the prescription, but nobody can administer it but that patient. Okay? There's a lot of ethics with this, we're not going to just, they're not going to like walk in the office and say, hey, what it is, great, here's the prescription. There's going to be a lot of conversations about this. Make sure that that person truly understands what they're doing and that they're making this truly autonomously, right? That they know the full scope of what this entails and it's autonomous. If you are to stay where you is, you have to protect the confidentiality. And you also have the right to conscientiously object. If you personally do not agree with it, if you are not in support of that practice, you have every right to say, I'm not participating in that care. That is fine. The ANA has said you have a right to conscientiously object. Now, what we're going to see a lot in acute care is this idea of withholding, life-sustaining measures, limiting, or withdrawing. Some people call it life support. That's the old school term. More appropriate term is life-sustaining measures. These are advanced technologies that are keeping life, sustaining life. So what are some of those things? Mechanical ventilation is one. BiPAP can be one. If patients are on vasopressors, this is keeping their blood pressure elevated, right? Artificially helping with cardiac output. Dialysis can be one of these. Any artificial nutrition or hydration if the patient's not wanting to eat or drink, but we're providing it artificially. In some situations, antibiotics can be categorized this way. If that person's actively dying, we're giving this to try to address the sepsis or whatever. Very aggressive cardiac support like ventricular assist devices, balloon pumps. I don't know if y'all have heard about these yet. If somebody's actively, if they're hemorrhaging and we're giving blood, that would be like a life-sustaining measure, right? Withdrawal of this means where we've been implementing these and we're going to discontinue that. Withholding means we're not going to offer it to begin with. And not because we don't want to do it, but because offering that or doing that does not align with the patient's goals. If they have an advanced directive that says, I do not want to be on a mechanical ventilator, then we're not going to put them on a mechanical ventilator. Limiting it is we can kind of be selective. Like maybe they want code drugs, but they don't want chest compressions, which is really stupid because if you don't have anything moving the drugs around, they just stay in the arm. Putting it out there. But they can pick, yes, I want this, I don't want this. Yes? So life-sustaining measures, you can withhold withdrawal. Disease modifying is like curing. This is saying that death was occurring and we did something to keep life going. Okay, so cardiac arrest, respiratory failure, things where if we did not intervene, that person would die, but doing this keeps them alive. That's a life-sustaining measure. So ventilator withdrawal is something that we do fairly often. In the critical care unit, people come on ventilators all the time. Hopefully it's because their lungs are better. We can extubate, they're good to go. But there are times where we realize this person is not going to survive. They're in multi-system organ failure. They have neurologic impairment. For some, the family has come into a decision where they don't want this anymore. In their mind, it's now we're prolonging the suffering. Again, this is a family decision. This is not a healthcare provider decision. But the family, we're going to educate them. So some people call it terminal extubation. I prefer the term compassionate extubation because we're doing this to stop suffering. The patient's not going to get better, and all of it because we're providing oxygen to the lungs and it's getting to the heart. The organs are still, the brain is still going, the heart's still going. What they do with terminal extubation is that they are going to remove the ET tube and give oxygen and control symptoms. Sometimes we go a different route called a terminal weaning, where we just reduce the ventilator settings, but they stay on the vent. I had a patient once who was, her husband was adamant that removing the ET tube was killing his wife. He fundamentally disagreed with it. The team kept saying she's had an anoxic brain injury, she's not going to recover. He was staunchly against it because in his mind, his beliefs said taking her off the ventilator was going to kill her. However, he had no problem with vasopressors because I asked him. Granted, it was like a whole thing. Nurses were like, I'm never taking care of them again because they were so frustrated because this woman was being kept alive when she had necrotic fingers and toes and all her organs had shut down because he didn't want to extubate. And he had every right to say no, but I asked him, well, how do you feel about these vasopressors? He's like, well, what are those doing? They're keeping her blood pressure up. They're keeping her blood flow. I said, but they're also why her fingers and toes are black. They're cutting off her blood flow to her fingers. How do you feel about those? Well, I don't care about those. How would you feel if we stopped those? What would happen? Well, her heart would probably stop, her blood pressure would drop, that she would probably die if we stopped those. But you leave that tube in, right? Yeah, we would. Well, that's fine. You can do that. Told the doc. I said, hey, he's okay with stopping the vasopressors. Well, how'd you do that? I said, because I talked to the man. And it was like an hour conversation of explaining where we were at. And no new information was being shared, but reminding him of everything. So the doctor's like, well, go do that. I'm like, no, he gets to pick when we do this. He gets to do his rituals that he needs to. He gets to say goodbye. Sure enough, when we stopped the vasopressor, she died within 3 minutes, but she was still on a ventilator. Right? So in his mind, he said, then that was God's will. Okay. But other times they'll say we want them off. So again, it's conversations and it's facilitating what the family wants. So sometimes taking them off the ventilator is extremely distressing, but maybe we can back off the ventilator settings And if the heart, if we deoxygenate the blood, the heart stops. So this is very detailed steps about what you're going to do. I'm not going to read these to you. This comes from clinical practice guidelines of how we do this. But essentially, we need to clear the airway first. We're going to provide, but here's the thing, people cannot die in restraints. If you are ever going to stop a life-sustaining measure, those restraints better be off first. Because a patient dying in restraints is a reportable event. So get those restraints off first. But at first, we're going to just make sure that they're getting pain management. We're going to back off the sedation. And then here's the steps for what you're going to do with your extubate. Thing after you do ventilator withdrawal or terminal extubation or whatever you want to call it is comfort. If they look like they're in pain, treat their pain. If they look like they're in distress, help their distress. Don't suction them, please. That's mean. Okay, but again, y'all can read these steps here. Artificial hydration and nutrition. This is when we're providing tube feeds or we're providing TPN or we're providing IV fluids. Families in the South, especially, food is love. This is huge in Alabama, right? My cooking is what makes them happy. So I want to feed them. Well, people who are in the end stages of life are not hungry, y'all. They are not getting thirst triggers. They're not hungry. The body does not have a metabolic demand for nutrients, and it is normal for them to not want to eat or drink. It's incredibly distressing for families, though. This is one of the hardest ethical things that we come across in dementia care, is that person's no longer eating or drinking. If you provide the body with water and nutrients, it can sustain for a very long time. It is a lot harder to make the decision to stop than to start. So I think it's important that we have very honest conversations before we do these interventions than asking them to stop later on. A lot of times people who are actively dying, if we start providing like enteral nutrition, you're actually creating distress. The gut's not asking for nutrients and you're putting it in there. You tend to have vomiting, cramping, nausea, lots of abdominal extension, bloating that can lead to pain. Typically, it's gonna, for people who are actively dying, it's gonna do more harm than good. Pain management and end of life. People are so afraid of opioids, y'all. If a patient is in the hospital and has pain medication ordered and they're dying, assume pain is present. If they were in pain before they became unconscious and now they're unconscious, you better assume that pain is present. We can, in situations of severe symptom distress, we can give palliative sedation as well, where we can induce unconsciousness because the symptoms are so bad that the only way to provide relief is to sedate. That has to be done in a healthcare setting. But the thing I want you guys to understand, there's this doctrine of double effect, because people are so afraid. Well, what if I give the opioid and they stop breathing? Does that mean I killed them? Right? They're so afraid of the respiratory distress. Okay, well, they're dying anyway. We're in an end-of-life scenario. The goal is to provide patient a good death without suffering. So the doctrine of double effect says if the action is good and your intention is good, you can do it. So if you give the pain medication out of a desire to relieve suffering and the end result happens to be respiratory depression and death, you're okay because your intent was to relieve suffering. Now, if you go pushing a whole bunch of opioid because you're sick of this patient and you're ready to off them, no, that's not okay. There was a nurse many years ago who got in big trouble because of going out and giving a bunch of elderly patients in a nursing home insulin and they were dying. I'm doing it compassionately. No, killing a bunch of people, that's euthanasia, sir. This just happens to be the side effect. If your intent is to relieve suffering, it's okay. I had a patient with Stevens-Johnson syndrome once, and we had wide open morphine on her. I was not worried about respiratory depression. I was worried about the fact she was shaking from pain, and I wanted her to have pain relief. Morphine doesn't have a ceiling effect. You can keep going up, so we were pharmacists like, are y'all drinking this? Like, nope. She needs it. There were other nurses who were like, you could never pay me enough to hang morphine wide open. I'm like, I'm good with it. She's in pain. So you have to know where you stand with that. If you're not comfortable with it, it's okay. If you're comfortable, you know where your intent is, you're good. Some other things to know: organ and tissue donation. People who die, who have brain death are eligible for this. Tissue can be donated after death, even cardiac death. This has to be Ideally, it's documented. Texas driver's license, I think, lets you note. I haven't gotten mine yet. 4-month waiting period is very ridiculous. But anyway, we want it documented. Just know that if you're the nurse and you're caring for a patient who could be potentially an organ donor, you do not bring that up. Because it could be perceived that your interest is more in getting the organs than in providing good care. So TOSA is the Texas Organ Sharing Alliance. Hopefully y'all learn about organ donation at some point. They will do the conversations. It's your job to make them aware that there's a patient. There's criteria in the hospital where anytime there's like a patient on a ventilator and there's some neurological involvement, you have to call them. Doesn't mean the patient's going to die, but you have to alert them. They're going to monitor. If the patient gets better, great. If things worsen, they're going to keep an eye on things. Do not be the one to bring it up. Nurses can lose their jobs if they overstep that line. Let TOSA do it. With resuscitation, it's, hopefully y'all listen to that critical care environment. Remember, people, if they understand at end of life, they choose not to a lot of times. You can be a full code, which means give me respiratory support, give me compressions, give me drugs. Chemical codes really should just go away because it's like, here, put all the meds in my vein, but I want compressions. Then how do you circulate those to the heart? Chemical codes don't really work, but it's a choice. And then comfort measures is where you're not going to do those advanced aggressive interventions. DNR is being changed into a lot of places we're calling A&D, where you're allowing natural death. DNR, do not resuscitate, sounds like we're just stepping back. Not. I'm done. Allow natural death is where you're going to step in and you're going to provide comfort during dying. You're allowed that process to continue. That has already been started. Here is the Texas rules for pronouncement. You have to know your state practice regulations. In the state of Texas, too, nurses can independently assess a patient if they're not on mechanical ventilation. They have to have life support staff. The patient is not on life-sustaining interventions and they died. 2 nurses conduct an assessment and they can confirm and pronounce death. Know your state. In Alabama, nurses were never allowed to do that. They could do an assessment, but they had to report findings to the physician, and the physician had to be the one to document that. So know your rules. So this is from the Texas statutes about the nursing scope of practice, so make sure you know what you can do here. So let's talk about what you do at that dying stage. Again, patients have rights in death. I'm going to try to get through this. So people die in different ways. Sudden death, that acute death, right? Out of the blue, trauma, death occurs. We can also see with terminal illness, a lot of times they're trucking along at a certain level and then they see a rapid decline. So that might be your cancer patients, people who they're all right and then they sort of just have a rapid de-escalation. Organ failure, this is where we have kind of a slow decline, but we might have an exacerbation where things get really worse. We get them out of that, but they never get back to where they were at. Kind of this downward decline. And then in frailty, just as people get older, they have a slow decline as well. So we can see these 4 different things. People can have a cardiac death or a brain death. Y'all learned about brain death? Not seem like resounding things, like it's all this stuff, so no. So cardiac death is where we have a cessation of cardiac functioning, right? So brain, heart, and lungs are dead. Brain death is where the neurologic, everything from the medulla up is no longer functioning. They've lost all neurologic function. These people are on a ventilator, and as long as the heart and lungs are getting oxygen, the heart can continue to beat. This person is diagnostically dead. There's a lot of testing that's done. You as a nurse will have to help with that. Okay, you'll learn more about that. Brain death is eligible for organ donation. But y'all don't be afraid of the D word. It is okay for us. In the state of Texas, where nurses can pronounce, you need to say they're dead. It's not a big, like, Grey's Anatomy, time of death, zoom in on the clock, breathe. Right, it's not a big dramatic thing. But you have to, don't say they've passed on, don't say they're not here anymore. Don't be like, time of death, you can just say your loved one they died. If families don't hear the D word, sometimes it doesn't click as well. We have to say the D word. Everyone dies their own way, and I've already talked about all those, but we have to respect how everybody wants to die. There's lots and lots of things we're going to see. in dying. These are normal, expected, but they are your responsibility to symptom manage. So just because somebody's dying doesn't mean we let them suffer. So here's the thing. If you're caring for somebody who's actively dying, use your discretion with assessments. Do we need to be doing every 4-hour assessment? Maybe not. We're going to monitor and respond to changes in these symptoms. There's 2 pathways people can take when they die. One is this, there's 2. It's the usual road, the one we as healthcare providers prefer. It's when patients just slowly slip into unconsciousness and they just peacefully die. The other route, the difficult route, is extremely distressing for families, extremely distressing for healthcare providers. This is where people might hallucinate. They might get agitated. As the organs start shutting down, we see an increasing in restlessness. It can progress to seizures, extremely distressing for families. But how do we know? What are those signs that we as healthcare providers are going to see that cue us into the fact that death is probably very close? This, for urine output, if it's decreasing, we know that perfusion is decreasing. This tells us, okay, we're getting closer to the end of life. If the extremities start to get cold and mottled, it's because we're no longer getting good cardiac output. We're no longer perfusing those extremities. That is something we need. If we are in a state where families are in an end of life, right? They're at the bedside of somebody who's actively dying. Let them know in advance. Nothing's more distressing when they sit down and they try to hug their loved one or they put their hand on their cold. Because they think cold means dead. So we know this is part of the process. So prepare them that their hands might get cold, their arms and legs might get blue. This is part of the body just shutting down, and it's not painful. It's not. Not only are we not perfusing, the nerves are not getting blood either. They're not firing. So it's not painful. Watch your vital signs. We never go from normal sinus rhythm to asystole. Hollywood sucks. We have all these different rhythms in between. All families know is flatline is bad. So if you're in a setting where maybe there's a cardiac monitor, can you turn that monitor off? It's still on the nurse's station. Nothing drives me crazier than when a family, they're at the bedside and they're staring at the monitor. Because when they reflect back on that time with that person, what do they remember? The monitor. Do they remember their loved one in the bed? No, because they would turn it off. Why do we care about alarms? We know we're going to get alarms because we're going to desaturate. We're going to get to an asystole. Turn off the alarms. Silence the things. Just help that family be fully present with that loved one. Breathing changes can be very distressing. People will change dopes towards the end. So every time we change dopes, is that periodic waxing waning, they get to those periods of apnea. Family members start holding their breath. Does that mean, wait, they're not breathing? Was that it? Are they dead? And then they breathe. Wait. So they just don't, you can't predict change dopes. Let them know breathing can change. And we're going to just keep an eye on them. If they don't know that a period of apnea can occur and then they get to that, all of a sudden they're going to think, what has happened? Let them know ahead of time. If they start getting delirious or confused, that's part of normal dying, but we still want to help with symptom distress. So letting family members know what these signs can be before they occur is going to help relieve some of the fear and anxiety of being at the bedside of somebody who's dying. We also need to do other assessments thinking about psychological needs, spiritual needs. There's so much fear in dying. Not right in that end of life period, but as patients are getting sicker every time they have an exacerbation. They're worried that they're going to be in pain and suffering. They're worried about what happens after I die. They worry about dying alone. Allow them to express those fears and help them think about how can we make sure you're not suffering. What are those things we can do to help support you? They might say things that indicate some spiritual distress. We do want to know their role of spirituality and religion. If we think there's some distress, maybe talk with them or get a chaplain to come talk with them. Social culture, we gotta know the rituals. I took care, I keep saying all the bad things. I do good end of life care now, but early on I didn't. I took care of a patient from Mexico, who happened at Methodist Hospital, by the way, but I hope they've gotten better. But he was from Mexico, was visiting San Antonio, had a major myocardial infarction. Brought to the emergency room, he was in the cardiac ICU with us for some time, actually was getting better, ended up re-infarcting, and was not doing well. The family was like, we cannot go through this again. So they decided to allow for natural death. We took him off BiPAP. And me being the good nurse that I am, or I thought I was, I said, would you like me to call the priest? And the wife, who I can still picture, she yelled at me, why would you call the priest? Well, your chart says you're Jewish. It's like, we've been in this hospital for 3 months and not a single person has ever actually asked what our religion is. Okay, well, what is it? She's like, we're Jewish. Oh. She was fuming. So she said, we call a rabbi. I'm like, okay, I'll go find a rabbi, like, awful. Ask early. Do not assume somebody from Mexico is Catholic. Was that awful or what? Somebody said, oh, he's Mexican, he must be Catholic. Smack that person. That's all I remember me, but she likes to smack people in her mind. Okay, we want to know their religion. We want to know what are those practices. After that, I was trying to backpedal. Thankfully, I cared for that man for 3 months, and they liked me, and so they forgave me for that. But then I started asking questions that I should have asked forever ago and found out there has to be a male present with him at all times after death, that the body cannot be left alone because they believe that the soul needs to have somebody with them, and it has to be a male. We have all female staff that day. So we had to work with the rabbi and the family to figure out how were we going to respect that. When we have other patients, maybe they need to be turned toward Mecca before they die. What do we need to do to make sure that we uphold their spiritual religious practices at death? In that situation, it was very distressing because that faith system said that they need to be buried with all of their organs, including their blood. The only way to ship him back to Mexico was to embalm him. Talk about stressing. We were finding this out as the patient was dying, and the rabbi said, it's okay. We follow the law of the land. We follow our religious beliefs. I was like, oh, I'm so thankful for him, because he was like, if what it takes is embalming to get him back and bury him where he needs to be buried, it's okay. Like, okay, great. Ask the questions. Document it. And do what you can to respect it. Don't make assumptions. So we want to know, where do they want to be? If somebody is dying, where do they want to be? If they're at the hospital, they're like, I'm done, I want to die. Can we get them home if that's where they want to be? Who do they want there, and who do they not want there? Do not let that person in? Okay. Who do they want to be there? Okay, I'm sorry. Visiting limits whatever, right? If they want a family at the bedside and this person's dying, can we get that family to the bedside? COVID sucks. I think we all can agree that, but what can we do? Maybe we can use technology to get the whole family virtually there. What can we do so those people who they want at the bedside can be there? Always asking them, is what we're doing aligned with what your goals are? If we're not meeting their goals, we're doing something wrong. Early on, asking how they define quality of life. I have a patient who, he defined quality of life as being able to hear John Wayne movies. Okay, I'm sorry, that is not how I would define quality of life, but for him, that gave him fulfillment. And even though he was a blind, bilateral amputee on dialysis because he had long-standing uncontrolled diabetes, as long as he could still hear, he could mentally picture those John Wayne movies. So I left Turner Classic Movies on. Thankfully, it was like a John Wayne thing. As long as those were playing, he was happy. He said, when I get to a point in my life where I can no longer hear, my life is not. Then that's where I lose my meaning. Okay. Ask how they define quality. I mean, who knows? It could be John Wayne. You never know. In Alabama, it could be Alabama football. I don't know. Be honest. If you don't know, it's okay. But keep in mind, when y'all are stressed, do you hear everything we say the first time? No. Do you hear everything we say the second time? No. Be prepared to repeat yourself a lot. Families are in distress. You might just be like, I've already told you 3 times. Answer it again. How many of y'all have had that already with family members? Like, wait, so what was the blood sugar? 256. No. 256. Yes, question? No? Okay. Okay, I know we talked about this. And also, don't be like, hey, can I do anything for you? No? Okay, right? Stress means they need time to think. So allow time for some conversation and some thinking. So the critical care environment, we talked about family conferences, but in critical care settings, we want to have family conferences. We want to make sure family members are on the same page. This is huge when you have family members who are disagreeing. These tend to come up a lot when we don't know what the patient's wishes were and we're trying to figure out what's the plan of care that's best going to meet what we think their wishes might be, and family members disagree. Family conferences, we want to get the team together, make sure we're all on the same page, get everybody in the room, and let's hash it out in a respectful way. I've done these many times. Once was a family with 5 kids and none of the 5 kids agreed. And they all were hearing different things from us. We were saying the same thing, but what they were interpreting, what we were saying was very different. I commandeered our break room. We all got together. We all sat and talked, made sure everyone heard the same thing and understood the same thing. And we left that room with a plan of care that everybody agreed on because everyone was on the same page. They understood where mom's health was and where it was headed. So that's how you do that. So if I set it up, have to align with goals of care. You have to know what they are, so you're going to ask. When it comes to interventions, though, in the dying process, you have to make sure it aligns with goals of care. And I say that because maybe aligning with goals of care means you don't do something. Now, dyspnea, we want to respond to, we want to address. So what are those things we're going to assess? If there's a reversible cause, and it's not going to be against the goals of care to treat it, let's do that. We might give pain medications. Maybe they're dyspnea because they're in pain. So we give pain medications, anti-anxiety medications, but get the head of bed up. Help them breathe better. Cool the room, get air flowing. Maybe some of those things can help. Maybe oxygen if it's with the goals of care and you have an order for it. Don't use an expectorant unless that's really what they want. A lot of times this dyspnea is not from gunk, so. Pain, we've already talked about. Your number one thing is going to be using your family members to your advantage. When a patient's unresponsive, we don't know why they're in pain or if they're in pain. Family members, especially caregivers who've been caring for that person for a long time, they might pick up on a furrowed brow or a tensing of the shoulders before you do. So a lot of times I would ask, do they look comfortable to you? Do they look like they're in pain to you? And if they're like, you know what they do, okay, I'm going to treat it. And if they went unconscious in pain, assume pain is present. Try to see if it's reversible. If they're constipated, that's very painful. Are there other reasons they might be in pain? And then again, don't be afraid of giving them pain medications. Typically, we don't need as many, but if somebody's been on pain meds chronically, don't cut them off. Do not cold turkey discontinue opioids because you're going to send them into withdrawal and you're going to create distress. We can give oral. We have liquid forms of morphine we can give. I can roll down the throat. What are some other things? Can we do massage? And educate, right? People are so afraid of being in pain. They're afraid that family members are afraid. If you give that to them, you're gonna make them stop breathing. Okay, no. We're giving this to relieve pain. Yes, it might, but a lot of times we know that when we give pain and we treat pain, they live a little longer because they're not fighting. Their bodies are more relaxed. Some people think, oh, you're old, you're supposed to be in pain. Wrong. Treat pain. And if they're dying, who cares if there's risk for addiction? Treat the pain. If you're chronic illness and you have reason to have pain medication, let's allay those fears of addiction. Delirium is incredibly distressing. We often miss it. Y'all hopefully saw that KMIC that I talked about. Hopefully we can reverse it. Again, there's lots of reasons for this. If somebody's dying, don't give antipsychotics. It's a very last resort thing. There's other things we can do. try to reorient, try to control the environment, support the families. Patients who are dying and are delirious aren't really aware that they're delirious. It might not be very distressing for them. It tends to be more distressing for the family members. So make sure that patient's safe and help support the family members. Sometimes family members at the bedside are calming. It's a familiar voice. If it's making it more distressing, maybe the family member might need to take a break. Would you like to step outside for a little bit? We can keep somebody here. What do they need? All right. This is the rough one. Terminal secretion. Okay, I have to have a loogie in my throat to make that lovely sound. That is not what's happening here. Terminal secretions are lovingly called the death rattle. This tells you you are in the last 8 to 23 hours of life. You are in that last day. We're starting to see impairment of the respiratory system. We see it a lot with people who are dying from a respiratory issue. It's very scary to family. Every time they exhale, they're like, and they just want it to go away. But the thing to keep in mind is it's not a loogie in the throat. You cannot suction and get a death rattle out. It is what's happening in the airway as that patient is dying. If there's a cause, maybe they're overloaded. If it's aligned with the goals of care, maybe we might do some diuretics, but what's the goal? But if we're giving fluids and they're dying, maybe we don't need to be giving fluids. Let's get that head of bed elevated. Don't suction, because all you're going to do is increase intracranial pressure. You're going to increase distress for the patient. Nobody ever loves being suctioned, right? Have y'all been suctioning? They cough, they're gagging. Why would you do that to somebody when we're trying to facilitate peaceful dying? Educate the family. If they're very, very distressed, families are very like, oh, this is really distressing. We might give an anticholinergic to kind of dry it up. That comes with side effect stuff. So we want to be very mindful and educated. Here's the thing. People who are dying can sometimes spike a fever. Well, it's because organs are shutting down and there's inflammation occurring. If it's aligned with the goals of care, sure, give out an antipyretic. But being real aggressive with fever management, let's put cooling bags on it. No, what is the purpose? A lot of times we're just going to let the fever ride if we're letting death occur. We have talked about it already, but people who are dying do not have a desire for food or drink. They have a decreased intake. Their organs are shutting down. Our responsibility is good oral care. We do want to make sure they're not getting mouth ulcers. Oral care is huge. I had a guy with dementia who was in the last week of life or so. All of a sudden, he respiratory failed. He went into respiratory failure, cardiac arrest. Couldn't figure out why, or not full cardiac arrest, but his stats hit the pavement. What happened? Well, he was still a full code at this time. It was after this we ended up having some good conversations. When we went to intubate, we opened the mouth. He had a plaque that had built across the entire upper palate and down the throat. He had a plaque that completely obstructed his airway. They suctioned that out. They cleaned his mouth. Airway restored. He came back. He was fine. It's because he refused oral care for days. Everyone just said, patient refused. He has end-stage dementia. He ain't refusing anything. He doesn't understand what's going on. Nobody tried to push tissue. He had mouth sores that were developing a plaque, and nobody thought to do anything about it. Don't feel them. Mouth care is critical. This is where when your family members are like, the food is love. Yes, but maybe they don't need food, but they do need oral care. Maybe you could help us keep the lips moist. Maybe you could use a toothpaste, help keep the mouth moist. They're still doing something, right? Food, mouth connection, whatever. That's a great way to help families feel like it's kind of a good substitute if they can't give food for love. Incontinence. Yes, as people die, they lose bowel and bladder function. But we don't want them to be having uncontrolled pain and symptoms because we're letting them get excoriated. We're letting them have skin breakdown. We want to still do good care. Before you go shoving a catheter up somebody who's dying and incontinent, let's think about goals of care. Could we maybe do a condom catheter if we're worried about excoriation? Or maybe we just need to be more diligent with our incontinence care. If they're agitated, what are we going to do? Consider if there may be a spiritual distress or some anxiety, and maybe we can use some relaxation techniques. Maybe they could talk to a spiritual counselor. This is clearly before they're unconscious, right? Sometimes restlessness is because they have urinary retention or they're constipated. If they are restless, do not restrain them. Keep them safe, but don't restrain. Somebody dies in restraints, that's a reportable event. And putting somebody who's restless and agitated because they're dying in restraints is only going to increase the agitation. So think about your environment. Is it really noisy and bright and chaotic? Can you kind of control the environment? Maybe that will help. We frequently see constipation. I don't care if people are unconscious and dying, they still have to poop every 3 days. If they aren't, and we start to see maybe some signs of distress, maybe it's constipation. Before we go crazy treating it though, what's the goal of care? But we might need to do some intervention for that. For families, again, we want to do grief and bereavement support. Your focus is comfort, psychologically, socially, spiritually, physically. People don't want to die alone. I keep telling stories, but I had a patient who was dying in end-stage heart failure. The wife had lost a husband several years prior to end-stage heart failure. Here's her new husband, or her second husband, dying the same way. She told me, I can't do it again. I cannot be here and watch this again. It almost killed me the first time. I cannot do it. And she said, I have to leave. Okay. Patient held on and held on and held on and held on and was just kind of hanging on. So finally I just went in there. I said, I talked to your wife. She made it all okay. She says it's okay. She'll be all right. Then we started seeing some change. And he ultimately died. I can't say what goes on there. I've been at many bedsides where somebody granting permission changed something. I had a bedside where a patient was trucking out forever. She had no vital signs. One of the 8 children who was holding out finally said, Mom, it's okay, I love you, you can die. Boom. My favorite one is a woman who was 93 years old, had long-term heart failure. The family had her on BiPAP and said, this is not the life we want for Mom. They take the BiPAP off, she gets 20% stats. This is not what we want. She's never going to get better. She's 93, we're done. So we take off the BiPAP that morning. I figured, me being the smart self, don't ever give a timeline. So make sure you say your goodbyes before we do this, because if her stats are hitting 20, she's going to die really quickly. I told them this because I thought I knew better. And they're all at the bedside crying, holding their mom, reminiscing and reflecting. They're like, our mom has watched Wheel of Fortune every single day since that show started. Really? Wouldn't it be great if Mom could watch it one more time? Yeah, what time's that on? I don't remember. It was like 2 or 3 in the afternoon, right? I was like, her stats are 20%. It's 9 a.m. That's not going to happen. 12 o'clock, the cardiologist comes to the unit, comes over to me. Why have you not called me with time of death? Like, she's not dead. Can't give you a time of death yet. Like, go figure that woman would be the holdout. Like, he was not surprised. She was a fighter. Wheel of Fortune starts. I'm thinking, how is this possible? Like, all the other nurses are looking in, like, how is she still alive? Like, I don't know. It makes no physiologic sense. So the daughters are crying. They're reading the things, whatever, telling her the clues. We get to that final round. She starts to break. I'm like, you're kidding me. We pronounced her 2 minutes after Kate, Pat, Jack, and Vanna played. Like, are you kidding me? Now, I just think that's interesting, right? But sometimes people need permission. Hearing is the last sense to go. So they might not be able to see, but they are hearing. So be mindful what you're saying in the room. But sometimes if it's like, what are they holding on for? Maybe they need permission from somebody. This death vigil, make sure that you're not rushing families away. You are going to get a call from the house supervisor saying, hey, we need that bed. We saw that person die. Yep, they sure did. You can wait. That's the last time that family has to be with that person. Let them be there. Now, let's be realistic. If they say, our son's driving in from Dallas, he's going to be here in 5 or 6 hours, depending on Austin traffic. Maybe not. But if they want 30 minutes or an hour to be there and to say their goodbyes, do it. A little help will hit lay the bed flat. I didn't do that once in my early days. I left the head of bed elevated. The family needed an hour. You know what happened in that hour? Rigor mortis. So then the morgue came to get her. She was stuck at a 45. Lay them flat. But let the family stay there. They were like, this happens all the time. Like, kind of letting her out. Like, oh my gosh. Lay them flat. But don't put like the rope, don't try to force them out closed. That's more distressing. Clean them up, let the family be there. Don't rush that goodbye process. Know that you always have to call the coroner. When somebody dies, the coroner might say, yeah, they're good to go, or they might say, we want them. That's going to dictate the post-mortem care that you give. So what is post-mortem care? If the medical examiner wants that person, that same patient who was stuck at a 45, it was awful. She should have never come to me. She should have gone to the trauma hospital. She was strangled by a John because her husband was making her prostitute. She was killed out of the job. Awful, awful, awful. The John said it was a drug overdose. The cops came to check. I'm like, really? You see these fingerprints? Tell me that's an overdose. It was awful day at work. I hated that. It was so rough. They wanted her. So when she died, I had to leave everything connected because they had to figure out what happened. So if you have a patient, if they die within 24 hours of admission, the coroner tends to want to figure out what's going on, especially if it's an unexpected death. Now it's a 95-year-old person who died, okay, right? They're going to use their discretion. But if they don't want them, if they're like, that's fine. Let them go to the funeral home. Clean them up. If the family wants to do a bath, let them do a bath. But if it's been a code and the room's chaotic and there's stuff everywhere, maybe let's clean up the room a little bit before we let the family in. Now here's the thing, take the leads off. If the coroner wants them, only things that are invasively in. I didn't know this the first time I sent a patient to the coroner and I left the leads on. And the next patient got admitted and my boss was like, where's the leads? Like, oh, they're at the coroner. They're not invasive. Thankfully, they brought it back because I was like, I can't afford those. Invasive things. A lot of funeral homes, by the way, will like catheters to be kept in because bodies after death do leak, and so a lot of times they like for a catheter to be left in. If you've got a central line, a lot of times funeral homes like those to be left in because they can use those to embalm. Just being honest with y'all here, some tricks of the trade. But clean them up. Let the family be there. You don't need to necessarily be the one to talk burial, cremation, but when somebody dies at the hospital, we got to know where to send them. If families have no idea, there are morgues in the hospital, but that's not where we want people to go. We want them to be able to go straight from us to the funeral home so that they can be prepared for whatever that ritual needs to be. Family members might not know. Hopefully, if we've done good advanced care planning, part of what we figured out is where would you want to have your funeral? Where would you want to be buried, or do you want cremation or anything? But a lot of times social workers are going to have that conversation. Provide time for goodbye. A lot of hospitals are going to have rituals, like for veterans, for organ donors, there's some cool rituals. As the patient's dying, think about the environment too. Some hospitals will have like a little picture, like a dove or something that they put on the door. It tells the rest of the healthcare team, hey, there's dying in this room that's occurring. Maybe we don't need housekeeping to come in. Maybe food service doesn't need to come in. Maybe admissions or whatever. We need your insurance card. Not the right time to come in. So making sure that the unit knows what's going on, and we're very, very respectful. We're kind of minimizing how much disruption we're adding to that family. And again, once that person dies, don't just say, okay, here's the bed. Give some time to say goodbye. The last thing I want to talk about is you have to take care of yourself. We are seeing nurses leaving the health profession like crazy. Y'all have heard about this, hopefully. A big reason why nurses are leaving is because if they weren't exposed to a lot of death in their career before COVID hit, and they weren't necessarily equipped with some toolkit for how do I handle death. And a lot of it, we didn't know what to do. What do you do when you can't find family? And what do you do? But with this, we saw that it was patient after patient. Oh, that one just died. Great. Okay, they're going to go. Here's your next one. And nurses weren't grieving. They weren't allowing themselves to process those deaths, to feel those deaths, to talk about it. And that's not all the reasons. There's so many other reasons for it, but that's playing into it. So when you have a patient die, it is going to be sad for you, or you're going to feel, I hope you feel something. Now here's the thing, you can cry at the bedside. People will be like, I can't. Yes, you can, but you can never cry more than the family. Right? You cannot be more upset than the person losing their loved one. But you can be, if you're gonna lose it because you're stressed and like hormonal, leave the room. But you can. But you have to do it. Figure out what works for you. If it's journaling, if it's running. Me was calling my fiance / boyfriend / whatever, husband, whatever phase we were, but I've been with him forever. I knew he was not listening. He was playing his video games. I know it. Because he's like, huh? I just had to verbalize to somebody my distress. And then I felt better. So make sure you start figuring out what do you need to do for self-care now. Because I don't want you running away from the profession. Because death is going to happen. You got to talk to somebody. If you don't, you're going to get burned out. You're going to be those nurses who are like, I don't give a care anymore. Take care of yourself. And on that happy note, good luck on your test tomorrow. all this thing we're going to assess. Look, are there signs of organ damage? Are we not confusing? We've got to keep blood pressure and heart rate low and pain control. If they're in uncontrolled pain, it's going to increase stress, it's going to cause vasoconstriction, it's going to increase afterload, and make it very likely that that dissection can expand. Now, if they're dissecting, again, this is where blood is flowing into the layers of the aorta, they're going to stretch very quickly. This is going to expand very quickly, and it's going to keep tearing down the aorta. So once that area is full, it's going to keep pushing the blood down. You're going to keep seeing more and more and more separation. Until the point where the whole aorta pops, essentially, and then the blood just flows into either the chest cavity or the abdominal cavity. So this can be very painful. If it's above the diaphragm, severe chest pain, we're going to see those neurological deficits because we're not going to be perfusing the brain. We're going to have signs of coronary ischemia. We might infarct our extremities because blood's not getting through the brachial arteries or the subclavian arteries to the extremities. If it's in the lower abdomen, we're going to see more abdominal issues, back pain, abdominal pain, leg pain, organ ischemia. Regardless, in a dissection, we're going to see very rapid extreme hypotension. The blood is no longer inside the aorta, it's flowing outside of where it needs to be. Because it's not where it's supposed to be, we can have all these bad things. They can put pressure on the pericardial sac, or we can flow into the pericardial sac and cause it. Have you ever learned cardiac tamponade? Where the pericardial sac fills up, you can't put blood in and you can't get blood out in those situations. A lot of time we're going to get, if we are not very, very quick, and it's one of those acute dissections, we're going to get to exsanguination and death pretty quickly. If it's a chronic one where it's a very slow leak, not quite sure how that would happen, but it could happen. We're not going to get to that as quickly, but we still have to fix it. We cannot let a dissection wait. It does this, monitor it, and see how it goes. We've got to. So we're going to do very good blood pressure, heart rate control, calcium channel blockers would be preferred here. Potentially beta blockers, even more so if we need low. We want to keep heart rate around 60, and we want to keep systolic blood pressure around 110 or lower. We want this way lower, even in an aneurysm, because in an aneurysm, at least the blood's all staying inside the aorta. In a dissection, it's flowing out. We don't want it doing that. We're going to use some morphine for some pain control. We're going to watch out for that cardiovascular disease risk, right? So make sure we're perfusing our lower extremities. There's a 50% mortality within 48 hours for all the types. If you go into acute range, that number is going to go over higher. So you've got to emergently repair any dissection. Okay, so this should seem very similar to what we just talked about. If we're doing surgery, preoperatively, we want to say, okay, what are some knowledge deficits? We're going to do patient education. We want to make sure they're well hydrated. Dr. Schultz just said, right? We don't want to give blood until we fill the tank. So we want to make sure going into surgery, they've got a full tank of blood and fluid to perfuse. All those same things, we're going to monitor electrolytes. Which ones are we worried about? Potassium, calcium, those ones that can affect cardiovascular function. We're going to make sure that we're looking at coagulation risk. We don't want them bleeding excessively, because then they might leak out of their surgical sites. Hematocrit, we want to make sure they've got adequate blood and adequate oxygen binding capacity. And then emotional support. You've just been told, hey, you've got an aorta that could rupture at any minute. You think that's going to mess with your head? Yes. Yeah. So we want to make sure we're providing that support, not only for the patient, but also for the family, because this is a very high-risk surgery. Same thing with any open heart. Those families are going to be stressed and worried. Anytime you cross-clamp, anytime you put somebody on bypass, there's a chance the heart might not do what it needs to and restart or reproduce. So we have lots of emotional support. When it's a dissection, we do want to put their head and bed up. Okay, we want to keep everything, we don't want to put added pressure get them up, help the lungs expand. Quiet environment promotes the anxiety reducing techniques. We're probably going to put them on pain med and sedation because we don't want them agitated. Again, we're going to really get that blood pressure down to normal, heart rate down. And you are watching them like a hawk. I mean, it's like every 2 minutes you're cycling up blood pressure. These people will absolutely be in the intensive care unit. They will not be out on a med surg floor. We're going to watch those EKGs. In the surgery suite, again, they can go through the femoral arteries and put a little graft inside. Or if it's a big enough one, they're going to open up and do a full sternotomy and go into the chest. Or they're going to do a full abdominal incision and go into the abdomen. Major expensive surgery. If you want to be a nurse that works in the surgery center, you're going to be a surgical nurse. Sweet. I was under my jam. Here's the job of that nurse is to make sure we're doing good EKG monitoring, that we're monitoring vital signs. They will do angiography afterward, make sure there's no blood leaking out. If that ruptures, we're on all hands on deck. We want to get the blood out of the abdomen, out of the chest, so it's not causing more issues. If it's a blood clot, you want to thrombolytic it. Okay? We're doing a lot of things. I want y'all to just take a second look at this. Does this not mirror what y'all just talked about? You're going to do frequent assessments, right? Looking for stroke, looking for heart attack, looking for respiratory issues. You're going to watch for bleeding. Make sure that we don't have a tearing of those surgical sites. So the kidneys are still perfusing. We don't want to get infection. If they go through the femoral sites, we're going to make sure they're not bleeding out of the femoral sites. We're going to do frequent employee assessments. So bleeding would be when it's coming out. You can also see a hematoma develop. Those end up being really painful. Full disclosure, I've had to have 2 cardiac ablations in my life. They didn't make me hurt. I've had some great nerves. I've got an EKG of a heart rate of 28. Every day. Yeah. But I got a hematoma. So it was like this huge big knot of blood. It hurt that whole leg and back for a while. So we want to avoid those if we can. Because then the body has to resorb all that blood, and it takes a while to do it. I'll tell you more of those stories later on. It was great fun. One was actually this last April, so sometime I'll tell you the story. Okay, so you're going to check the puncture site. You're going to monitor your ventilator settings. Make sure we're not going into respiratory acidosis or respiratory alkalosis because you're screwing up their pH. Make sure our vent settings are good. Monitor their positioning. Make sure we're monitoring our fluid and electrolytes. Pain management is critical. We actually want to get these patients up and moving within 24 hours, 48 hours of surgery. They are not going to get up. They're not going to deep breathe. They're not going to avoid pneumonia and get movement if their pain's out of control. So we have to be very diligent with pain management, infection prevention. We still want vital signs lower. We're going to try to keep heart rate, blood pressure in a normal range. Now, y'all heard surgically the gut might not wake up after surgery. So we want to monitor for that and treat as ileus if we need to. And then even after surgery, they are going to have to stay on medications long term to maintain blood pressure and heart rate in that normal range. And they're going to have to keep coming in for more monitoring. They're going to have to keep doing CTs or ultrasounds or x-rays to make sure that that graft, make sure that that repair is pulled. And it's not causing it. A lot of times you might see aneurysms above it or below it. So we want to make sure, especially if they're not keeping their blood pressure low. It can create a whole other world of problems. So we want to make sure we continue to monitor. What are those issues? Again, they could start bleeding out in a week. The aneurysm, we talked about it. All those same issues that could happen pre-operatively could also happen post-operatively. If you get bleeding into the abdomen, it can cause compartment syndrome. Y'all learn compartment syndrome, right? But you pretty much probably learned it like extremities. It can happen too. If you get a lot of blood pooling up in the abdomen, it can cause ischemia there as well.